Oh, toasty. I really need to get those rolls made for the Discord. Why is this? Why all of a sudden is this not working on my mouse? You can always find help by tapping here on the game. Why is my mouse not collecting that? Oh, I have a certain amount of bonus rolls. Okay. Okay, so it's not the chords. Why does this keep happening on my dock? horrible. I want to know why this isn't connecting my mouse anymore. You know what? I could have taken the forest. God damn it. Now I'm stuck. Because now none of this stuff. None of this matters. I don't know what just happened. And I won, but I don't know what just happened. Can this go back to connecting my phone, to the mouse, please? It's so much easier to work while doing this stuff, while it's doing that. Okay, so that sounds working. Maybe if I close this and open this again. Oh, my stream deck's not even connected. No. Very closely. It was working, and now it's not working, and it's going to irritate the hell out of me. The phone screen is open. Why are you not selecting this? There we go. That'll work. Welcome to Dice World. Play Dice Masters, enjoy new gameplay, and earn amazing rewards. Beat the Dice Masters levels to earn prizes and unlock the next Dice Master in the world. Some levels have fun obstacles that put your skills to the ultimate test. Win all the Dice Master levels in the world to enter the race. Nice high leaderboard. Okay. Well, first things first, I need to find friends. For that. pretty pink wallpaper. I will equip all the things. But first, I need to sign into an account, yes. Got it. Gonna work. Yay! Got it. Oh, the camera's not right either. Oh, I need to pin the message. Awesome. My credit card readers are messing up at the stores. Love that for me. Right. Oh, I like those dice. Yay! Oh, I need to blast this crap on the soldier. Yeah, see, I like the digital look a little bit better. Got this. And that's posted there. Do it here, and we share it here. Why does the selection of hashtags not continue when you reshare a post. It's kind of weird. Facebook is weird. I don't know if I'll be able to select a video. Maybe not. Gonna make sure the button's on. Oops. This way? This. It's gonna seem weird. We're gonna make a clip. Alright, you ready? Hey everybody, come play out Yahtzee with buddies with us, man. We're gonna do this fantastic game and help support the content for free by downloading the link below that's in the description. See you guys soon. Horrible. But you know what? I need a video, apparently, to post on certain things. Oops. Weird. We're gonna make a clip. Why does that sound weird? Is this not on the right mic? It's not on the right mic, which explains why that sounds like crap. Alright, we're gonna delete that again. Hey guys, come support the new sponsored game Yahtzee with Buddies. I don't know about you, but I grew up playing with Yahtzee in the family. Check it out here. It's beautiful, beautiful color. It's free to play. Download it with the link below and you help support the channel. I'll see you guys soon. I hate doing clips live. But I've not hit the right button. Yeah, I know we're broadcasting. I want the clip. Is this gonna work when I'm live? I don't know if this will work when I'm live. Hey everybody, come play out Yahtzee with buddies with us, man. We're gonna do this fantastic game and help support the content for free by downloading the link below that's in the description. See you guys soon. Ready, come play out Yahtzee with buddies with us. It seems weird. We're gonna make it quick. See if I can find the better one with the right microphone on it. Hey guys,
Hey guys, come support the new sponsored game Yahtzee with Buddies. I don't know about you, but I grew up playing a lot of Yahtzee in the family. Check it out here. It's beautiful, beautiful color. It's free to play. Download it with the link below and help support the channel. I'll see you guys soon.
Why does that sound? Is that really because this freaking microphone isn't in the right spot? Well, it's not my fault. It doesn't stay up anymore. Yeah, see, I didn't even clip that one when I used the clip thing. Where is my highlight? Isla? Ela Hayes. Welcome. Yep, don't forget to enter the code MSSucks during your fast entries and get some extra entries into it. Because MS does suck. Not right now.
Hey guys, come support the new sponsored game Yahtzee with Buddies.
Don't want it to share to that page. I mean, I already shared it on that page. Oh, pick one. I don't know what a Clawitzer is, but okay. Alright, well that worked. That must work. Alright. Back to the game in between working. Because working is so fun. Hardy cat. Really? You couldn't just give me a 4?
go for a low full house? I guess we'll go for 2s. Come on, just give me the 2. I want a high level 4 of a kind, right? Because it's the sum of all the dice. So we'll take the 2s. If I get a 4, I can do a larger straight. That's not what I wanted. That's not what I wanted. Just give me the 4. The worst. Oh, now you give me a 4. 3, 4, 5. Give me a 6, please. Give me a 6, please, you son of a hoe bag. Oh, you gotta be kidding me, really? 3, 4, 5, 6. You're an asshole. What do you mean? Oh, I hit the wrong fucking button. Son of a bitch. Come on. Oh, that's garbage. Uh, 4, 5, 6. Give me a 3. You're not gonna give it to me, are you? You are a hoe. Oops, I don't know why I did that. I just want a 3. Thank you. Come on, thank you. What do I still need? I still need 1s, 4, 5, 6, and yahtzee. So we'll hold the 5s. Well, hopefully that's going to work for us anyway. Could have been worse. Really? You're not gonna give it to me? Oh, that's because I hit it earlier by accident, son of a bitch. That's right. I remember now. Yahtzee! Alright, isn't he fours? In the random. Did I already do that? I already did that. God, I just went through a bunch of bonus dice for that game. Six, five, four. Can I get free? It's not quite what I wanted. Let's hold those. No. Really? Cool. Oh, look at that. One, two, three, four. Give me a five. It's not a five. That's a five. Okay, so it must be the dock, because it's obviously not the chords. I just replaced these with better chords.
Ooh, look who's first.
We'll take it. Work is busy. Yeah, I'm supposed to be working. I still gotta figure out what I'm doing for dinner. Actually, I should probably figure that out before it gets too long. horrible. Can I redo that one? No? Okay. Really? You couldn't give me a single 4? Thank you. At least that's better than nothing. Although I only have like 3 bonus rolls left. I'm flying through those things, honestly. I'll take it. Maybe I shouldn't have taken it. Any 4s? Not a single 4 to be had. Complete the category. Oh, okay. 6s. Do I want to hold those? Yeah, it's fine. Well, 3, 4, 5, 6. Thank you. See, when I don't try, I get it, and that's dumb. That is not what that was. Okay. Oh, it locked me into that? Oh, that's weird. Why are you... Why does it say you can't refill it? I already freaking paid it. Honestly, I don't need any of these, but... Got some mobile dice, it is some mobile dice. We'll take it. Oh, I still need a large straight. 2, 3, 4, 5. Give me 6. Give me 6. That'll work. I just need a yahtzee. Well, where was that full house earlier? Bitch, really? No. So now am I stuck in this? Because I can't do anything? Oh, no, okay. I just essentially forfeit that card. Okay. Full house isn't some blessing. It's essentially the same thing I just deposited, okay. Alright, 3, 4, 5, 6. Thank you.
also need a large. So if I get a 2... And that is a 2. There's plenty of 2s. It's horrible. Wow. I'm not gonna win this one, ladies and gentlemen. Me too. You're an asshole. Alright, well, I lost that. I want a rematch. Oh, you're a dick. Yeah, put those 2s in. Oh, well, let's just do that. 3, 4, 5, 6. Wow, okay. Rip. Oh, of course, now there it is again. Go figure. Me too. Thank you.
iPalm. And then I just need either the yahtzee or to sacrifice the yahtzee. Yep. Oh, no, I need fours. Okay, did I win? Yay, I won. Why not? We'll just double up on that right now. Like that. That was beautiful. Well, that's not great. You bastard. Give me a 4. That's not a 4. Give me a 2. It's not a 2. It's not a 2. It's not a 2 either. You jackass. Really? Well, that didn't help anybody out. Three, 4, 5, 6. Seriously? One, 2, 3, 4. Give me 3. I'll take it. It's 24s, right? Oh, look at that. Thank you, Yahtzee gods. And twos, 4 of kinds, and Yahtzee. Well, thank you for that. I'll sacrifice that Yahtzee for that. Wow, that was horrible. Mr. Gilbert, thank you for your work, brother.
Holy fuck, is this wrong?
Burrito cat. Submit the score to pop the bubble. Multipliers inside the bubble will fly off and attach themselves to random score categories. Oh, okay. Got it. Thank you, I'll take it. We have 4? Really? It's abysmal. You already got the full house. I could go for as many 5s as I can get my hands on, apparently. Or a small. Why not? That is not what I wanted at all. I need a 3. Oh, you bastards, I can't. Guess we'll get the 4s. Brutus. Get some 2s. That's some ball dice, isn't it? Yeah. Two, 3, 4, 5. I need either a 1 or a 6 if I go with that route. Yeah. Okay, I'll take it. What do we need? 5s and 6s. That is not what I wanted. I will take the 3. That is not what I wanted, and I can't do the other ones. And sacrifice one of those, which sucks. Gotta sacrifice another thing, which sucks. Alright, 3s and 6s. And 5s. Oh, if I win this, it'll be by the skin of my teeth. Oh, I did it. Nice. Alright, so the downside to a game like this compared to like the Star Trek one, what was the last one we did? Foundation. Galactic Frontier is that like I actually had to participate in these ones. Well, that works, thank you. Three. I'll take it. Oh, no, so shit. I can't play anything. I still got 3 of a kind of thing. Three, 4, 5. I needed 2 or 6. You know, play the small. Oh, you know what? Damn it! I should have done that fucking large. I saw it right as I hit the button. 2, 3, 4. Give me 5. Beautiful. Thank you. I do need 2s. Those are not 2s. Those are 2s. Okay, so it has to be an issue with the dock. Oh, I don't need any of those. Bye. Yeah, I did it. I mean, either way, I need. I get a 4. It's not what I wanted at all. It's not what I wanted. Still not what I wanted. Any number of even numbers. Okay. Okay. Obviously, the more even numbers, the better, yeah. Like that. Give me a 4. That's not a 4. I can't do anything with that. You son of a hope egg. I don't think I'm gonna win this one, guys. Give me 2. 2. One, 2, 3. Or do I go for yahtzee? Come. That's not what I wanted. Wow. That was super bad. I lost. Thank you. Yeah, what a rematch. Hmm. One, two, three, four. Give me a 5. That is not a 5. That's a 5. Thank you. I get the same number. That's funny. Three. Oh, let's go for 4. That's not a 4. Wow. I got screwed. Wow. Will I win though? Beat Burrito Craft to win. Looping multiplier changes to a different multiplier value every turn until both players have scored. Oh, okay. 1, 2, 3, 4, 5. Nice. Right out the gate. Two, three, 5. I need a 4. Or yeah, I need a 4. Nice.
Well, that's not great. Shit. Well, none of these are great. You bastard. So close. You know what? I win. I'll take it. Oops, wrong one. This one. Give me a 4. Yeah, either way, I need a 4. That's not a 4. What am I going to throw away? Two, three, 4. I need a 5. Beautiful. Thank you. Oh, then I get a straight without even trying.
wouldn't freaking give me 4, would you? Oh, it's not super big. Wow, that was abysmal. Oh, well, at least on the bright side, I think I won this one. So close. Or do I go for... to go for the straight? I'm gonna go for the 4s.
+1907.
Hello? Hey, yeah, hold on a second. I can't hear you, hold on. I got too much shit going on. Little girl, what do we want for dinner?
Maybe restaurant.
We're not doing a restaurant. We still have to go to Taekwondo tonight. You want to do a restaurant? No, we don't need to do a restaurant after. Why don't... You know what? We can do... No, I don't know if we have enough egg roll in a bowl stuff. I was gonna say, we could do chicken egg roll in a bowl, because we have a bunch of chicken that's still left over, but I don't think we have the coleslaw we normally use for that. So...
Spaghetti!
We had spaghetti the other night.
Cereal!
I do cereal for dinner. I mean, I can kind of do what Mommy did. Mommy made mac and cheese.
And, veggies.
Yeah, she put mac and cheese with broccoli and chicken. I don't know if I want to do that again. We just did that, though.
Yesterday?
Huh?
Yesterday?
It was the day before yesterday. Yesterday, Dad did chicken and veggies.
Oh. We can do...
But if we're going to pull something out of the freezer, we got to pull it out, like, now, so it thaws in time. Alright, let's go hunting. Let's go see what's in the freezer. I'll be right back.
I'm not sure what that means. Coordinated universal time. I thought that was the universal time code, like UTC. Not a coffee. Correct. Now I'm out of coffee. And what was left was cold. Oops. Well then. Yahtzee! Do I go for the 3 of a kind, or do I go for... you know what, we'll do the 3 of a kind, because it's not a horrible number. Well, that was shitty. One, two, three, four. I need a 5. It's not a 5. That's a 5. Thank you. Yeah, another Yahtzee! Only you could do it twice. Well, I did not expect that to work that way, but okay. I need 2 3s and 5. Hi, beautiful.
Do you know how many backpacks I have?
Do I know how many mini backpacks you have? No.
3.
You have 3?
I have my unicorn, my axolotl, and my strawberry.
Oh, okay.
We're not just looking for my unicorn. Where are you? Unicorny. Unicorny. Oh, there you are. Thank you.
energy refills for free until the cap is reached. Well, thank you. Tap here to play now. Pick boxes to win amazing prizes for free. Rewards get better every stage. There's always a bust hiding that will take away all your rewards. Gross. There are no busts on jackpot and super jackpot stages. Exit with your rewards whenever you want, or keep playing to try to earn more prizes. Oh, can I make it all the way to 30? Ah, damn it. Oh, really? That's so sad. It's probably not going to work because I'm doing the thing differently. That's so sad. Because I'm not doing it as a screen share instead of actually playing the app on the computer. Oh, I gotta do some work shit real quick. Alright, so actually what we'll do is we'll get some videos going real quick. Nobody asked you.
Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people living with MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS navigators are online throughout today's program, answering those questions and connecting you to resources. Some MS symptoms are not always well managed by FDA-approved medications, and a growing number of people living with MS are exploring medical cannabis. Dr. Michelle Cameron is joining us today to discuss the risks and benefits of medical cannabis and how people living with MS are using it. Dr. Cameron is a neurologist and physical therapist and a professor in the Department of Neurology at Oregon Health and Science University. Welcome, Dr. Cameron. Thanks for being with us today.
Thank you. It's a pleasure to be here for you and your audience.
Medical cannabis is a popular topic, and before we dive in, we'd like to address any legal concerns people may have. Dr. Cameron?
Sure. So just to be clear, I'm a physician, not a lawyer, and I'm not your doctor. So this information is not medical or legal advice specifically for you. For specific medical advice, consult a qualified physician who's your physician. And for specific legal advice, consult a qualified attorney. But in summary, cannabis, marijuana, is a Schedule I substance under the Controlled Substance Act. This is federal law. So under federal law, Schedule I substances are drugs with no currently accepted medical use and a high potential for abuse. They're not allowed. The use, sale, and possession of cannabis that contains over 0.3% THC, and I'll explain to you what THC is a little later, but over 0.3% of THC by dry weight in the US is illegal under federal law. Now, state laws in many states do permit cannabis use under various circumstances. Those state laws vary from state to state. The National MS Society supports the right of individuals living with MS to collaborate with their healthcare providers in determining if medical cannabis is an appropriate option for them in compliance with state laws. And if anyone is exploring treatment with medical cannabis, consider state law, federal law, implications for your employment. I live in Oregon, where state law says cannabis use is legal, but as a physician, and particularly a physician working in a hospital, I may not use cannabis. My employer would fire me if they thought I was doing that. And of course, the clinical knowledge, which is what I'm going to really focus on today. But this sort of sits there in the background to everything we speak about. Thank you.
Thank you for that clarification. I always like to begin these kinds of conversations by being clear on our definitions. And when this subject comes up, people use a lot of different terms: medical marijuana, cannabis, THC, and CBD, to name just a few. So I'm hoping you can get us started by helping us understand what the terms cannabis, cannabinoids, medical marijuana, and medical cannabis each refer to.
Sure, we'll sort of take this from the top and work our way through it. So cannabis or marijuana are basically the same thing. They're the plant that is cannabis. So that's a plant with leaves, flowers, And in that plant are chemicals that act on your nervous system. The chemicals are called cannabinoids. So the plant is cannabis, cannabinoids are the chemicals in the plant. And then when we put the word medical in front of it, medical marijuana or medical cannabis, that's really the same stuff. We're just saying you personally are using it for medical reasons. It's actually not any different than any other kind. It's just what you're using it for.
And I heard you just mention those chemicals. Can you help us understand the difference between THC and CBD?
Sure. So those chemicals, cannabinoids, there are actually over 100 chemicals, cannabinoids in cannabis, but the most prevalent, the ones that are the highest concentration of, are THC, tetrahydrocannabinol, and CBD, cannabidiol. There's no quiz. I'm not going to ask you to spit those back at me. But THC is psychoactive. That's the thing that makes people high. That's the thing people tend to like because it's fun. CBD is not intoxicating, so not fun necessarily. Sort of barely feel it, might make you a little relaxed, but can still have therapeutic effects. And so those two chemicals are in cannabis, two different cannabinoids, and they can be in the cannabis in different proportions. And you'll see that if you buy cannabis.
How do cannabinoids work in the body, and why are more people with MS using cannabinoid products?
So there's always a little bit of hand waving if we don't know how things work. But with cannabinoids, we know there are two cannabinoid receptors in the body. So your body actually also makes cannabinoids, those same types of chemicals, and those chemicals bind to receptors in you. When you take cannabinoids from the plant, they also bind to those receptors, and then that has downstream effects on your immune system potentially, and on your nervous system, and on other organ systems. And so then you say, well, why are people using cannabinoid products? Well, people are using them sort of as you started with, John. We have a lot of medications for MS, both to try and control the disease and to control the symptoms, and neither are perfect, particularly our symptomatic medications. So people are using cannabinoid products to try to further help control their symptoms.
We heard from Brian, and he's wondering if prescription pharmaceutical cannabis products are available and whether any of them are FDA approved to treat MS or MS symptoms.
Well, let's not make assumptions about where Brian lives. So if Brian lives in New Zealand or in Canada or many parts of Europe, the answer is yes, there's one prescription pharmaceutical cannabis product available to treat spasticity in MS that hasn't responded to other therapies. But if Brian lives in the United States, the answer would be no, there are no pharmaceutical cannabis products available to treat MS or MS symptoms. There are no FDA approved cannabis products to treat MS or MS symptoms here in the United States. There is one prescription pharmaceutical cannabis product that is approved in the United States. It's a CBD only product, and it's actually for very rare forms of epilepsy. Quite different. But for MS or MS symptoms, no approved pharmaceutical cannabis products in the US.
What types of medical marijuana products are there, and what are their different methods of administration?
So, oh my goodness, if you've been, as I say, I live in Oregon where recreational and medical cannabis are legal, and the range of products is huge. So flour that people can smoke, there are distillates that people can eat, there's gummies, cookies, and that's just to name a few. So there's all sorts of products, and basically the primary route of administration, people are either smoking it, so inhaling, or they're swallowing it. It's oral in some fashion, or oral mucosal, they're putting it in their mouth. And then there are topical products too, so things you put on your skin, either a lotion, a cream, something you put in your bathtub. So huge range. And then again, as I said, some have more THC, some have more CBD, and that varies too.
Well, we've heard from Charlie, and Charlie wants to know whether there's evidence to support the potential benefit of any medical marijuana products for people with MS.
So almost the entire evidence or research is actually on this one pharmaceutical product that's available outside the US. This is an oromucosal spray. So you spray it in your mouth, and it's half THC, half CBD. And the evidence supports that it reduces patient-reported spasticity, although not when we measure it as a provider tries to figure out how bad your spasticity is, and seems to also reduce pain, although the evidence for spasticity is the strongest.
Raina tells us she's wondering which marijuana product at which potency will be best for her. Dr. Cameron, clearly this process isn't as simple as just having a prescription filled. With so many options, how does someone even begin?
So I think it takes a mix of things. Raina, as you might guess, I won't give you personal medical advice here on the screen. So it depends. A general principle is start low, see how you feel. We'll get into talking about side effects too. So how's it going to work out for you? But start with low dose, start low, and then build up and see what, if and where you hit the sweet spot of having the effect that you're looking for, controlling likely spasticity or pain without side effects, or without side effects that make it not worth it. And where do you begin that journey? That usually should be start with your physician. Ask them if they think this would be helpful for you. And then you may end up working again with a dispensary because of the huge range of products they have to come up with what works for you, if there is something.
There have been clinical trials to evaluate the impact of cannabinoids on MS-related symptoms. What does research show about the efficacy of cannabinoids for treating MS-related pain?
So yeah, as I mentioned, the evidence is decent, but always a little tricky. That cannabinoids, that one-to-one CBD THC, does seem to be helpful for MS-related pain. Now, it doesn't make it go away completely, but seems to have an impact.
When we think about the common symptoms people with MS deal with, 85% of the people living with MS experience spasticity. Can cannabinoids help people who are experiencing spasticity?
So that's probably the symptom that's the evidence is the strongest for, that this right one-to-one THC CBD combo may help reduce your experience of spasticity. Not everybody, but seems to help. Reduces it maybe about 30%.
Violet wants to try medical cannabis for her spasticity, but she says she's embarrassed to bring it up with her doctor. Do you have any advice for how someone like Violet can start that conversation?
I think often that conversation goes something like, "Hi Violet, how's your spasticity doing? Not so well. Oh, what about these medications? Yeah, they haven't helped me, or they make me too sleepy." And then I think often the easy way is either, well, I heard this talk from the society and I wondered about it, so we've given you a little bit of a starting point right here, or the I know a friend conversation. One of my friends, somebody at a meeting said they tried this. Doc, do you think that would help me? So put it on the outside.
Carol tells us that she experiences bladder dysfunction and that impacts her whole quality of life. She wants to explore medical cannabis to help reduce her urinary frequency. Could medical cannabis help someone like Carol with bladder dysfunction?
It's always a tricky question. Anything could, but the evidence is not strong that this is likely to be helpful for her. I would try other things for sure. And even with pain and spasticity, I'd try other things first. But at least with cannabinoids, for those, there's a decent chance you'll be successful. With bladder dysfunction, much less so.
What do we know about medical cannabinoids managing or improving other MS symptoms like ataxia, tremor, and sleep disturbance?
So interestingly, again, these are symptoms people have looked at. We don't really have good evidence that cannabinoids are helpful for these. And sleep disturbance is sort of growing evidence that although some products may help you go to sleep, if you use cannabis for a while, then if you try to stop it, your sleep actually gets worse. And so it's a pretty slippery slope to try and manage sleep with cannabis.
Jessie says she's wondering whether medical marijuana can help with the emotional and psychological aspects of living with MS, like depression and anxiety.
So that's a really interesting question, definitely being looked at, even mostly outside of MS, to look at the psychological effects of MS, of cannabis, medical marijuana on depression and anxiety. I think the jury's still out on that. So maybe not, but we really don't know.
Although many people are finding relief using medical cannabis, it's not without potential side effects. What are the most common side effects someone might experience when using cannabinoid products?
So I think we can look at this from a few different angles. I think there's the THC intoxicating side effects that you probably expect. And we've all sort of run into cannabis out in the regular literature. So it probably won't, while you're using it, make you smarter, right? If you're high, you're probably not thinking quite as well. Doesn't improve your balance, could make you more unsteady. If you have balance problems, that could be a serious issue. You could feel dizzy. You could be hungry, the munchies. You could want to eat more. It can affect people. So really sort of thinking, balance, appetite are probably the most common side effects. And then thinking about it chemically, sort of a side effect is recognize that it can interact with other medications you're taking, making them work either too powerfully or less well. And this is part of why you really need to talk with your doctor. So if I'm going to do this, what's it going to do to the half a dozen other medications I'm taking?
We heard from Joel, who's living with MS, and Joel wants to know if it's safe for him to use medical cannabis, or are the risks higher for people who have MS?
So Joel, again, I'm not your doctor, so I don't know what else you're doing, what else you're taking, what's with you in general. So this is really a conversation between you and your doctor. I think in some ways the risks are higher though for people with MS, because as I said, what are our big concerns? Cognitive, balance, and then interactions with other medications. And people with MS often have issues with all three of those. They may have some cognitive dysfunction to begin with, and then we put this on top. They may have some balance problems to begin with, and we put this on top. And then many people with MS are taking many other medications too, so the risk of an interaction is higher. So it's not that MS per se makes cannabis more dangerous, but for people who have it, likely yes.
Angela tells us she's overwhelmed by all the choices she has to make when it comes to medical cannabis. She's wondering if there is a professional that she can consult to figure out what type of medical cannabis product might be best for her.
Yes, Angela, it's very tricky. If you deal with an FDA approved medication, it's a single drug, it's got a given dose, you know what's in it. And the choices is, still, if you worked with your doctor to pick a disease modifying therapy for MS, your doctor's expertise is in that was a difficult choice. You may have changed it over time, but it's a bit more limited. When you think about cannabis, if you go to the store, it's like going to buy a bottle of wine. Think about how many different bottles of wine there are. That's the same as how many different cannabis products there are. So I don't have a perfect answer for you. I think you want to start again with your healthcare professional, with your physician to go, is this potentially worth trying for me? What sort of THC CBD combination might work for me? And then think about the route. If you're smoking it, it's hard on your lungs, but it works pretty immediately, so you know what you're dealing with. If you take something by mouth, it can take an hour or even two to work. So you could take a little, wait a half hour and go, this isn't doing anything. I'll take a little more. Wait another half hour, still don't feel anything. Take a little more. And then 2 hours later go, oh my goodness, I'm floating on the ceiling. That wasn't quite what I was hoping for. I caution you somewhat against using only the people in the dispensaries for advice about products. Although they certainly tend to know that product, they're not medical. So they may try to give you medical advice, but they don't really know about your disease. And so who knows what they'll say, but they are not trained medical professionals. So that's where I would not go.
Destiny says she's been looking at purchasing a cannabis product either online or perhaps going to Mexico, and she's wondering whether there are any safety or quality or potency concerns associated with making a purchase in this manner. She'd like to know if there are safer ways to obtain medical cannabis products.
Sure, Destiny. Again, a little will depend on where you live, what the options are. There are at least laws in many states that try to control the quality, the potency, so that the label accurately tells you what's in something. If it says it's this much THC and this much CBD, somebody's tested it, and that's true. They've also tested it for pesticides, other chemicals, fungus. Those laws vary from state to state. Some states it's completely illegal, so there are no laws beyond that. In each state that has legalized cannabis has slightly different laws about how it's monitored, but at least there's something. If you're buying a product from Mexico or online, that's, I guess I'll call it the Wild West out there. It's beyond the Wild West. There's no regulation. It's actually illegal to sell THC online, but trust me, people do, or they buy something that says it has THC on it online. That's what the label says. Who knows what's in there? Even in the dispensaries, you can't be sure, but you start to go online and buy it on the internet, you have no idea what you're getting. You've got a label, you've got something in a bottle, but what it is, I couldn't tell you. So if you're in a state where medical cannabis is legal, it's most likely that the dispensaries are your safest option. But until we have FDA approved products that are then monitored, there'll always be that little bit of uncertainty.
Thank you for sharing some important and very useful information with us today. What would you say are the top 3 takeaways that you'd like our viewers to remember?
So I think number 1, if you're using cannabis or cannabinoids for any reason, or you're thinking about it, wondering about it, please discuss this with your physician. I know it's not the most comfortable conversation. It's not the easiest one to start, but it's better to start it and have it than to just be doing that and your provider doesn't know. Nobody can take that into account if we don't know about it. Number 2, cannabinoids may actually help with your MS symptoms, particularly spasticity and pain, but there are also risks of side effects. So this isn't like anything else. It's not risk-free. So recognize it's a balancing act, start slow, and see if the benefits outweigh the risks for you. And number 3, remember there are no FDA approved cannabis-based medications for MS symptoms in the US, and cannabis does continue to be federally illegal. Thank you.
Well, thank you for sharing your expertise with us, Dr. Cameron. I think we have time for one more question. Alan wants to try medical cannabis for his chronic pain, but he's concerned he'll get addicted to it. What advice do you have? Can someone get addicted to medical cannabis?
So the quick answer is yes. And the more complicated answer is, so what we used to call addiction, we now call a use disorder. So an alcohol use disorder, a substance use disorder, and there's a cannabis use disorder. This is, in short, continued use of that substance despite adverse effects. You're losing your job, you're spending money you don't want to, it's making you more anxious rather than less anxious. It's making your life worse, but you're still doing it. That's a use disorder. And about 9% of people who use cannabis develop cannabis use disorder, or have cannabis use disorder. So yes, do most people? No. And some people? Absolutely. So not completely benign.
Well, I want to thank everyone who submitted some excellent questions, and thank you, Dr. Cameron, for being with us today.
Thank you. It's been a pleasure.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on MS, please be sure to visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups. You'll hear about ways to get involved, and you'll find out about upcoming events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that I start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Dr. Cameron for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSExpert, as well as on Facebook and YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. On YouTube, you'll find that link in the program description. And on Twitch, you'll find that link in the chat. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Dr. Michelle Cameron and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices. Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering those questions, connecting you to resources. Getting an accurate MS diagnosis can be a daunting task. MS symptoms can resemble other medical conditions, and not everyone experiences typical MS symptoms, which means that getting an accurate MS diagnosis can sometimes be tricky. Joining me to shed some light on optimizing the process of diagnosing MS is Dr. Andrew Solomon. Dr. Solomon is a professor of neurological sciences and division chief of multiple sclerosis at the University of Vermont Larner College of Medicine. And he's an internationally recognized expert on MS diagnosis and misdiagnosis. In fact, Dr. Solomon was the lead author on a consensus paper written by international experts and sponsored by the American Committee on Treatment and Research in MS. The paper provides updated guidance for healthcare professionals on clinical approaches to diagnosing MS. Welcome, Dr. Solomon. Thanks for being with us today.
Hi.
It's not, of course, it's not unusual to hear that someone has spent months and sometimes seen several doctors trying to figure out what was causing their pain or their fatigue. Why is MS so difficult to diagnose? And I'll ask this question two ways. How long should it take to diagnose MS? And how long could it take to diagnose MS?
This is not an easy, quick question, but MS can be very different in each patient who has it, unfortunately, which can make it challenging sometimes. So sometimes it can take a little bit longer to recognize symptoms or MRI findings or laboratory findings that are suggestive of MS. We don't have one single test to diagnose MS right now. Our diagnostic criteria is a clinical criteria. Doctors have to take all this information and review it and make sure there's not a better explanation other than MS, which we call differential diagnosis. That's actually part of our diagnostic criteria, is this idea that there's no better explanation for the symptoms the patient's having or the MRI findings or the laboratory findings that we're seeing. And so, sometimes it's pretty straightforward to make a diagnosis of MS, and it's obvious there's no better explanation. But as this paper that we just published implies, there are many diagnoses that can mimic different aspects of MS. And so sometimes it's a process to rule those out.
I want to get into some of those mimics, and I also want to circle back to the diagnostic criteria in a moment. But first, can you talk about some of the more common symptoms of multiple sclerosis?
Sure. The diagnostic criteria even specify this. We have the way we diagnose MS right now is based on the symptoms and findings on examination, neurologic examination that patients initially present with. So in order for somebody to be diagnosed with MS right now, we need to identify a syndrome, a collection of symptoms that's typical for MS. It's the first step in making a diagnosis of MS. That includes things like optic neuritis, which is inflammation of the optic nerve, myelitis, which is inflammation in the spinal cord. There are certain syndromes involving inflammation in the brainstem, an area between the brain and the spinal cord, that can be quite typical of MS. And then there are patients who have, unfortunately, some gradual worsening of symptoms for a year or longer that can be quite typical for MS, particularly walking impairment or balance impairment. So identifying syndromes that are typical for MS is sort of the first step in the diagnostic process. And we're learning that there's a lot of disorders that can kind of present with the same kind of symptoms that look very closely like MS. And so there's a lot of nuance to evaluating whether or not that inflammation of the optic nerve has characteristics typical of MS or atypical, and maybe there's something that suggests a different disorder. So sometimes it can take some work to untangle that.
Well, given all of that, which tests and which healthcare professionals are typically involved in diagnosing MS?
Well, hopefully, usually a neurologist is involved in diagnosing MS. Um, yeah, I'll just start with that. Patients need to see a neurologist in order to receive a diagnosis of MS. We do what's called a neurologic exam, which is a little different than an exam that maybe a primary care doctor does, where they listen to your heart and lungs, but we test different parts of the nervous system. And that's really important for helping us determine, where a patient's symptoms might be coming from, and where in the nervous system it may be coming from. MS affects the brain and spinal cord, brain and spinal cord and brainstem, as I alluded to, but not typically, for instance, the peripheral nerves. So we can kind of tease these things out with the neurologic exam a little bit, and then figure out where to do further testing in order to investigate those symptoms. And that often involves MRIs and laboratory testing, blood work, and sometimes a spinal tap, lumbar puncture, to look at the spinal fluid. All of these things can give us a bit of information about diagnosis, but not one of them alone, is usually enough. It's sort of a combination of us sort of analyzing all of these elements. And some people don't need all of them. We don't always need to do a spinal tap, for instance.
Can you explain what the McDonald criteria is and its role in diagnosing MS?
McDonald criteria is our current diagnostic criteria for MS. It was really developed to predict a diagnosis in patients who've had an initial attack or symptom typical of MS. So in order for this criteria to work, a neurologist who's knowledgeable about MS and all the disorders that can mimic MS first has to determine if the patient's symptoms and presentation are typical for MS, and think about other diagnoses. Those two things have to happen before we can even use the diagnostic criteria. So the diagnostic criteria is good at predicting a diagnosis of MS in patients who present with a typical syndrome and who have where we've ruled out other causes of their symptoms. And there's different elements of this. There's different ways to fulfill this criteria, either by symptoms or MRI findings or spinal fluid, as we talked about. And we can confirm a diagnosis of MS using this criteria, but it requires us to rule out other disorders as part of it as well. So it has elements that are maybe familiar terms to some patients when they look things up. This idea of a typical presentation we talked about. We also have this idea of something called objective evidence. So a patient presents with a typical presentation or symptoms of MS, but then we want to see that there's objective evidence of a lesion or an area where there's an abnormality in the nervous system that explains those symptoms, right? So we can find things on an MRI sometimes, but they may not explain the symptoms the patient's having. So that would make it harder to diagnose MS in that situation. We could also have objective evidence of a lesion just by doing a neurologic exam. We can see something in the eye that can give us sort of confirm that there's inflammation or there's a problem with the optic nerve at least. So there's a typical syndrome, objective evidence, ruling out better explanations, and then the last part is something called dissemination in space and time. And this term is part of the McDonald criteria as well. And we need to make sure that MS typically affects different parts of the central nervous system over time. And so we need to make sure, in order to confirm a diagnosis of MS, that the patient's presentation fulfills those concepts. So we see more than one part of the nervous system affected. This could be by symptoms and evidence of a lesion on exam, or this could be by MRI changes in different areas. And similarly, over time, there are different ways for us to tell if something's changing over time. And that can be through spinal fluid or MRI changes, or even just a patient's description of symptoms in their neurologic exam. So it's sort of a long answer, but there are these core elements that need to be fulfilled in order for us to feel confident that we can confirm a diagnosis of MS.
I've heard it said that time equals brain. Can you talk about why getting a timely and accurate diagnosis is so important?
Sure. It has to do with our treatments that are available for MS. So over the years, particularly over the last 20 years, we've seen as we've revised our diagnostic criteria for MS, we've been able to diagnose patients earlier, and they've been able to start disease-modifying therapy earlier. And there's a sort of a preponderance of evidence that early treatment of MS with these disease-modifying therapies can prevent disability short-term, but also long-term. And so patients can do a lot better if we can diagnose them early. That's sort of my short answer. We don't have a cure. I wish we did right now. But overall, patients are doing better as we're diagnosing them earlier.
A few moments ago, you mentioned that other health conditions can mimic MS symptoms. Can you talk about some of the specific disorders that mimic MS and how they can make getting an accurate diagnosis more challenging?
Sure. This was the focus of this recent consensus paper that you all alluded to in the introduction. So there's a really long list of disorders that can mimic MS. And I think as MS specialists, we think about these disorders when we're seeing a patient. Some of them are quite rare and unusual and can be tricky. And sometimes it can take time to really appreciate that a patient may have one of these disorders, unfortunately, rather than it being easy to diagnose right away. But there's also been a lot of data, over the last maybe 6 or 7 years about MS misdiagnosis, patients who are given a diagnosis of MS who don't have it. And there's also been a lot more data on two particular disorders, long names. One is myelin oligodendrocyte glycoprotein associated disease, and one is aquaporin 4 neuromyelitis optica spectrum disorder. There's been a lot more data about those disorders that really have a lot of overlap with how MS can present. So these two areas have given us a clue of the disorders that maybe most frequently may be mistaken for MS. It's not comprehensive, but what's interesting is while we have a lot of rare disorders that can be mistaken for MS, in many of these studies, they're very common disorders that are being mistaken for MS. So disorders like migraine, for instance, which is quite common. Migraine can cause MRI abnormalities like MS and can cause symptoms like MS. There are other patients who have neurologic symptoms and happen to have an MRI where there's some scarring or what we might call lesions, areas where there's been a prior injury. But those MRI changes don't explain their symptoms, but we see that maybe neurologists are relying too much on the MRI and not as much on the patient's history and neurologic exam, and that results sometimes in misdiagnosis. Those are common. So high blood pressure, things like smoking can cause these white matter abnormalities on MRI, and a patient might have a totally separate neurologic diagnosis, but sometimes we mistake this for MS, much like migraine. And then I mentioned these two other disorders, and we're finding that these disorders can present with optic neuritis, and they can present with myelitis, and other symptoms similar to MS. So we have some testing that can help differentiate them from MS, and new diagnostic criteria, including diagnostic criteria published this summer, that can help us. So I would say that the most common misdiagnoses probably right now are common disorders that cause MRI changes that are sort of frequent in the general population, where neurologists are sort of relying a little bit too much on the MRI than we should. And these other disorders that cause CNS inflammation like MS that we've learned about really in the last 5 years for one of them in particular. That's my short answer, but there's probably there are a lot more to talk about. I mean, there are rare disorders that can mimic MS too that can be quite challenging sometimes and require a lot of expertise.
When I first introduced you, I wanted to make sure that our viewers knew about your paper that provides updated guidance for healthcare professionals on clinical approaches to diagnosing MS. What was the main goal of that research?
Thanks. Well, so there was a paper in 2008 by a bunch of international experts that tried to comprehensively provide guidance to neurologists on what to think about when they see a patient where they're considering MS, and this was an update on that. So we had 22 authors, I believe, on this paper from around the world who had a lot of different aspects of expertise in MS, and this paper focuses on how to approach these syndromes we talked about, how to approach patients with optic neuritis where we're worried about MS, or myelitis where we're worried about MS, all the syndromes that are commonly thought of as typical presentations of MS. And then we also created these pretty impressive tables of what we might call red flags. So clinical findings, something you might notice in a patient in terms of a symptom or something when you examine them that should raise a red flag and say, well, maybe this is unusual for MS. We should think about these other disorders. And there's another similar table looking at MRI red flags. So there are all these clues that we've, collated from experts around the world and all the literature in the last 15 years that we have in these tables that should be sort of warning signs that, they don't necessarily exclude MS, some of them, but they should, prompt some consideration of disorders other than MS. And so it's an attempt to have all this data in one place and in a way that's accessible to non-MS specialists, to doctors globally, to doctors in training. There's a lot of, the previous paper in 2008 has been very useful for neurologists in training as well, people training in MS expertise. So it's a hopefully something that will inform practice, but also help with education.
So it sounds like by educating and informing practice, we get to more accurate MS diagnoses quicker. Yes?
Yes.
We heard from Ronald, and he's wondering what we've learned about inflammatory disorders in the central nervous system that can help healthcare professionals arrive at a more accurate MS diagnosis.
Well, I talked about these two disorders, and I'll focus on them a little bit. So I'll mention them again: neuromyelitis optica spectrum disorder and myelin oligodendrocyte glycoprotein associated disorder. Many of these patients used to be diagnosed with MS. For NMO, which we didn't have a highly sensitive or specific test for this until I think around 2005. And we're really, for what I abbreviate as MOGAD, we're really learning a lot about patients with that other disorder over the last 5 years through these large cohorts of patients. And what we're learning is that those disorders respond differently to treatment. They have different prognostic implications, and they're quite different than MS in a lot of ways. And we've learned a lot of clues about the syndromes that are typical for MS and how to identify these other disorders. So, for instance, optic neuritis in MS has, tends to present in one eye or involve the optic nerve in a certain way, whereas when we see both eyes involved, or if we see the outer covering of the nerve involved and inflamed, called perineuritis, or if we see the back of the optic nerve involved, we might want to think about these other disorders. And that's really new data. I mean, we used to think of optic neuritis, if we've ruled out some other things and we see some abnormalities on the brain MRI, that it's likely MS. But now there's a lot more nuance to thinking about these symptoms as well as the MRI findings that are associated with them in patients with CNS inflammatory disease. We have a lot better data, more granular data to help guide us for the correct diagnosis.
I want to bring up a couple of terms that our viewers may not be completely familiar with. Can you explain what a central vein sign and paramagnetic rim lesions are and how they can help provide a more accurate MS diagnosis?
Sure. These are exciting avenues of research right now. So these findings are on MRIs, and they seem to be very promising. We would call them biomarkers, right? Promising findings that can tell us something diagnostically. So in some disorders or diagnoses in medicine, we have like a blood test, and we can say with this blood test, we know you have this diagnosis, or this blood test is pretty good at predicting this diagnosis. But in MS, we still don't have that, which has been a challenge. But central vein sign and paramagnetic rim lesions seem to be specific for MS in some ways. So central vein sign is this finding where we see a vessel or a vein in the middle of these white matter lesions that are common in MS. There's special sequences or ways of taking the picture, the MRI, that can show this better than others. And this is an area of ongoing research. But what we're finding is that many patients, we've known for a long time that patients with MS, since the 1800s, have veins in the middle of these lesions in the brain. There's some relationship between the blood vessels and inflammation that causes these lesions. But now we can see it on an MRI. And if most of the white matter lesions on the MRI in a patient we see have that central vein, it makes it more likely to be MS. And there's been a lot of studies now that have shown that. And there's a very large 400 patient study sponsored by the NIH right now that's ongoing, that's looking at how well we can use this finding to diagnose MS. We need to sort of get a bit more research to understand what number of central veins and where to draw the threshold in lesions will be predictive of diagnosis and not lead to false positives and these sort of things that are complicated. But there's a lot of really compelling data that this might help us with diagnosis in the future. If we see an MRI with a lot of white matter lesions or spots or scarring with a vein in the middle, it may be predictive of a diagnosis of MS, and that might be really helpful in patients who are diagnostically challenging. The second one, paramagnetic rim lesions. So we are seeing that on MRIs with patients with MS, around these white matter lesions that are common in MS, these bright areas, there's a dark rim around them sometimes. In some studies, it's been about 50% of patients with MS have one of these. So that's very different than the central vein sign, where every patient with MS has lots of them. So that means that this test is not going to be as sensitive for MS. We're not going to be able to use it alone to diagnose MS if only half the patients with MS have this finding. But it also seems very specific. It seems like an area of inflammation around the white matter lesions, and we're not seeing this in other disorders. It seems very specific for MS. Unlike central vein sign, it also seems to have some relationship with how people are doing. So patients who have a lot of lesions with this dark area, it might mean there's some smoldering inflammation around those lesions, and some of those patients are more disabled. So it's also becoming an important target for treatment trials. So studies involving new medications for MS are now looking at this paramagnetic rim lesion and seeing if we can make it go away, because we see that people who have more of those have more disability. So that one is a biomarker that might be useful for not only diagnosis, but treatment. And ultimately, we'd like maybe to combine both central vein and paramagnetic rims and help us, diagnose MS in the future. And there's a lot of really important work going on, particularly by an organization called the North American Imaging and MS Cooperative, looking at these.
It sounds like there's so much good work going on in terms of identifying reliable imaging biomarkers, fluid biomarkers. There's a lot of excitement about how artificial intelligence can aid in the diagnostic process. Let me ask you, how do you see MS being diagnosed in the future?
That's a good question. So I'm not sure. Honestly, I'm not sure. So when the McDonald criteria, for instance, work really well under perfect conditions and where people are quite knowledgeable, but that's not always, sort of possible. And we've had recent study this year, in fact, last month in France, and a study that we did in the United States that showed that a lot of doctors out there, who may see MS, but also see a lot of other neurologic disorders, may not be as familiar with our diagnostic criteria as they should be. They don't understand what some of the terms mean or how to use it. So we can develop perfect tests that are sort of highly accurate, but if the doctors who are using them aren't as familiar with them, they're not going to work, right? So I think, right now, I think our biggest barrier is education. Like, I'm figuring out how to disseminate, all this new information about diagnoses that can mimic MS and how to use our diagnostic criteria accurately. Like that will improve diagnosis globally more than anything. And I think that will be the same challenge with these biomarkers. So right now they're not perfect. Machine learning might help us. So or artificial intelligence. It might say you have a certain number of central veins and paramagnetic rim lesions, and we might be able to get that feedback from an MRI, like a readout. And I think that'd be really helpful. And same with some of these emerging blood tests that might be helpful for diagnosis of MS. The less we have to rely on a doctor staring at an MRI, sometimes, or to count these things, or if we can discriminate them with high accuracy, using artificial intelligence that was trained by people who are very experienced, it may really help us diagnose MS more rapidly in a global setting, And so I'm hopeful for artificial intelligence in that way. I don't mean to dismiss MS is a clinical diagnosis, and neurologists are critically important right now in navigating all of what we just talked about today. But the tools that we develop to help diagnosis need to be made maybe less error prone. Humans all make mistakes, unfortunately, myself included, and we need to figure out ways to help with that.
We heard from Adriana. She has an interesting question. Adriana says she's going through the process of being diagnosed right now, and she's wondering if or how she can best manage her symptoms while she's waiting for that confirming diagnosis.
That's hard. I don't think anybody should be managing their symptoms on their own. So I think it's part of the job of us as neurologists to try to help patients with symptoms during the diagnostic process. So if she's suffering from symptoms, neurologic symptoms, I'm hopeful that she can find a neurologist who works with her to help manage those symptoms, even if we're not certain what's causing them. We have medications that help with a variety of neurologic symptoms that can be caused by like many diagnoses, right? Neuropathic pain or spasticity are not specific to MS. And hopefully there's options out there for her that her neurologist can think about.
Well, at the beginning of our conversation, I said that you were going to shed some light on a process that, as you said, can sometimes be confusing. You've shared some really important information with us today. Let me ask you, what would you say are the top 3 takeaways that you'd like our viewers to remember?
Gosh, I think I think number one, for patients, is that this diagnosis is not always straightforward, and I think for all of us humans, uncertainty sometimes is harder than being certain about a bad diagnosis. Like having things just be up in the air can be really hard on us, and unfortunately, MS diagnosis can leave us in that kind of limbo for a period of time, and we might need more information, more MRIs, more testing until we can really feel certain. And the better that we can sort of prepare for that when somebody brings up the word MS, the better we might be able to manage. I'm hopeful that someday that won't be the case, but sometimes it can take a little bit of time. And uncertainty is part of MS. Once people are diagnosed too, I mean, that's a really hard part of the disease, right? I mean, we don't know when somebody might have a symptom or things can change. We have not really very good ways to predict how somebody's MS will act and how disabled somebody might become or how much risk there is of disability. So I associate a lot of uncertainty with MS once you're diagnosed too, which can be really, really difficult. So number one is to just expect uncertainty sometimes. Number two, I think it's reasonable to ask your doctor why they think you have MS. If somebody is telling you have a diagnosis of MS, I think having them go through the process with you of explaining why they think you have MS and why they don't think it's something else and how you meet the diagnostic criteria is really important. Because some patients do have lingering wonders about other diagnoses sometimes, or they read about something online, but you really want to feel confident in that your doctor was thorough and considered other diagnoses and that you do fulfill the diagnostic criteria of MS. Sometimes we do have patients who we think have had one attack and they're very likely to develop MS, but it just hasn't happened yet, and we treat them. And that's a different situation, but that's still something that we ought to talk and explain. And I think the last bit is that we talked about that misdiagnosis unfortunately is common, and it's not entirely avoidable at this point because we don't have one test for MS that's 100% accurate. Asking along the way, do you still think this is MS, is not appropriate. Things do change, and a lot of doctors get into what we call anchoring bias. So once we've made a diagnosis or somebody else has, we're less likely to question it, and that's a problem because sometimes things change over time that might suggest that there's something else going on. So I think it's okay to question it, with your doctor occasionally, and they should be able to answer that question.
Well, I want to thank everyone who submitted some excellent questions today, and thank you, Dr. Solomon, for being with us.
Thanks for having me.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS navigator by phone, email, or through the Society's website by chat. For information and resources on MS, please be sure to visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups. You'll hear about ways to get involved, and you'll find out about upcoming events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Dr. Solomon for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and on YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. On YouTube, you'll find that link in the program description. And on Twitch, you'll find that link in the chat. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Dr. Andrew Solomon and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.
Hey guys, we are back, obviously, but I still do have some work shit to do. So we're going to keep learning some MS shit. I'm going to change
Welcome
my
to this
category
week's
on
edition
on
of
the channel.
Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering those questions and connecting you to resources. MS can impact your ability to perform day-to-day tasks and be productive. Yes, you do have control over your environment. Whether you're looking for a new place to live or you want to maintain living independently in your current home, there are professionals who can help you understand options like home modifications, technology, and accessibility features, all designed to make it easier for you to live safely and comfortably in your home. Joining us with strategies for making your home safe and more accessible is Tracy Carrasco, an occupational therapist at Orlando Health's Multiple Sclerosis Comprehensive Care Center. Welcome, Tracy. Thanks for being with us today.
Hi. Thank you for having me.
When I introduced you, I mentioned that you were an occupational therapist. And when people hear that term, they sometimes think that the work you do must be related to their job somehow.
Right.
Can you explain what an occupational therapist does and how your work can benefit someone who's living with MS?
Right. So I do get asked that a lot, and I probably have to explain it daily. What I do as the OT is I'm looking to help people who may be disabled or injured become as independent as possible in their environment. And we also always try and think about what the patient really wants to do, or is required to do, or is interested in doing, and how we can make that happen. So we can utilize different strategies or tactics to help them, or we can think about maybe equipment or changing the environment they're doing a task in.
Which other members of someone's MS healthcare team does an occupational therapist regularly work with?
Well, you mentioned that I work at a comprehensive care center, so I'm really lucky. I work with the rest of my rehab team, which involves, which has physical therapy and speech therapy. And then we work closely with the neurologist and the nursing, and the MAs in the clinic. We have a social worker as well. So it's a rather comprehensive team. And then we have also other resources which are in the hospital system that we can refer to, such as respiratory or dietary, or if there are vendors in the community that might help us with bracing or splinting, or wheelchairs or other mobility devices too.
I think sometimes it's a question for many people as to when to ask for some help. So I'm wondering, should someone who's living with MS, who may be experiencing minimal mobility issues, should they start considering occupational therapy?
We really do want to bring them in, not just to the occupational therapist, but the whole team of rehab. And we really like to get them in pretty early after diagnosis. And that gives them all the education and information that they may need, as well as establishing a good home program to think about wellness behaviors and exercise so that they can maximize their independence throughout the diagnosis. And it also gives them a nice connection. So if anything does occur that's not normal to them, or they have a new symptom develop, then they can always come back to us, and we're familiar, become kind of like a family.
You know, we heard from Angela, who tells us that she's in her 50s and she's lived with MS for about 15 years. Angela has started seeing a decline in her hand dexterity. She's struggling to put on clothes that have buttons, zippers, or clasps, and she's experiencing foot drop more frequently. Angela's goal, she tells us, is to continue living independently for as long as possible, but she's not sure where or how to start addressing these changes in her physical status. So would occupational therapy benefit someone like Angela?
Most definitely, yes. I would probably say that both occupational and physical therapy physical therapy would address more of the mobility issues, as far as maybe bracing or a device potentially needed to help them get around more easily, or her around. But I would focus on things that are affecting her independence as far as her daily activities. You mentioned dressing skills, any of those things that she needs to do around her home every day. We want to make sure that she's independent and she's safe. So in the clinic, I could address the coordination issues, and we definitely start by doing some baseline testing to see where she's at and what kinds of issues she's having. Oftentimes, people will come in and say, I think my hands are getting weaker, I can't tie my shoes, or I keep dropping things. And then as we do a full assessment, we may find out, oh, there's some sensory issues going on, or it's not the hand strength, it really is truly a motor control issue. So those are treated differently, but we would have a custom plan to be able to help her improve that. And then, of course, if need be, we can give her some assistive devices and let her trial them in the clinic, such as button hook aid, or changing the way she ties her shoes, little things like that. And then beyond that, we can go into the home environment and look at bigger picture, what could make her more safe with her mobility in her environment. So that's where equipment, or changing the way she has her things set up at home, her furniture, or her bathroom, to make things easier.
Well, speaking of that home environment, Candy tells us that she has a combination shower and bathtub, And she feels unstable stepping into and out of the bathtub and while she's taking a shower. Now, bathrooms are a common place for at-home falls and accidents to happen, so it's important that Candy addresses this. What tools are available to help with balance in the shower, and what other modifications can be made in the bathroom?
Yes, again, a really common issue. And you're correct. Very frequently falls occur in the bathroom. So we first would start out addressing what she has set up. You mentioned a tub or shower. So we would look into potential equipment that could help her without having to do a whole new bathroom modification. However, in an outpatient setting, I might ask them to bring in pictures for me to see if we can kind of problem solve that just from a distance. There are different types of bathroom seats or benches that are available so that she could get in and out of her bathtub independently. Grab bars are also really useful. And then the question also becomes, is this a rental home or is a permanent home? Are we able to make permanent modifications to the home too? Because sometimes that's important to our, as far as doing more in-depth modifications, that's when maybe we can come out as an outpatient therapist. I can come out into the community and do something called a home modification. That's where I would go in and do a detailed measurements and be able to bring equipment or talk to people about modifications that could be made specifically for their home. Or we might even consider sending home health therapists who could work with that patient over several visits to try and see what would be the best options for them, whether it be equipment or an extensive modification. So lots of questions, and it's really customized to each patient.
Greg recently experienced a relapse that has affected his vision. He says he's not seeing things as clearly as he used to, and while he was at home, he recently tripped on a pillow because it blended right into the carpet. What steps can Greg take to maintain his independence and stay safe while he's at home?
That is definitely a home modification because everything in his environment is going to affect him if he's not seeing it as clearly as he used to. We like to look over the area. Very frequent falls risks are things like throw rugs or, like you mentioned, items that blend in to the floor coloring. So we can help with things as far as explaining and educating on contrast of colors, perhaps look into improving the lighting in a home, decluttering the home so there's not as many chances of falls if there's nothing in the way to trip over. Again, we can do that as a home evaluation. A home therapist can do a great job with that as well, to go in and kind of look at the environment.
We heard from Roberto, who tells us he works from home, he uses a walker to get around, and he often gets fatigued moving from his bedroom and office upstairs down to his kitchen downstairs and then back again. Roberto recently panicked when he left the oven on and then found that he was just too exhausted to walk back downstairs to turn it off. What options does Roberto have to make his home easier to maneuver in, and are there any technology-based tools that can help him avoid problems like the one he experienced with his oven?
So we have this question a lot about stairs in general, and I know it's not always possible, but the first thing that we might discuss is actually seeing if his office or bedroom could be moved to one single story so that we eliminate having to do the whole up and down the stairs, which could be very fatiguing and then puts him at a higher risk to fall. Other things, though, are talking about energy conservation with him and talking about maybe having everything in one room so that he doesn't have to go up and down the stairs often. And you mentioned technology. So a really good resource for that is using the home assistants, for instance, like a Google or an Alexa. Or you can just use apps on your phone. Many appliances and different things around your house can be controlled through electronic devices. So he could actually tell his Google Assistant or his Alexa to turn off the oven. Another thing, he could have all of his appliances kind of wrapped up into an app and be able to turn that off. I'll say that actually did happen to me. My freezer contacted me when I was on a cruise ship leaving Miami, told me that the temperature was raising. So I was able to call my neighbor and say, hey, can you stop by the house and see if I left it open? And sure enough, I left the drawer open. So they can be really handy, and they'll contact you, they'll help you out. Very, very nice.
And they never call in sick either, so they're always on the job.
Right.
We heard from Philip, who wants to know whether there's any technology that can help his wife, who has MS and struggles with cognition. What services or products are available to help Philip's wife take notes or provide her with reminders while she's at home during the day?
Wonderful. Yes. So just to be clear, in our clinic, we have an occupational therapist, myself. I have a speech therapist who also works with cognitive skills, and myself, and also neuropsychology. Neuropsychologists treat them as well. What I would work on is a lot of exactly what you mentioned. How can we be safer in the home? How can we be independent? Again, a lot of electronic devices, and really just your smartphones, can be a huge help. Sometimes people are afraid of technology, and so they might be able to come into our clinic and we can help set them up, setting up things, for instance, teaching them how to use the calendar and reminder app on their phone. They can set alarms or alerts for themselves. And that truly, with cognition and someone's daily activities, it really needs to be customized to them. Some people love the technology. Some people would rather stick with pen and paper, and that's okay too. And I have plenty of people who use combinations of both. So we can help set up a scheduling system and use those different devices to help remind them in case they forgot things.
Karen says she's primarily at home during the day and sits in a recliner until her care partner gets off work and transfers her back to her wheelchair. She frequently misses package deliveries or visitors at the door because she's unable to see who it is and doesn't always feel safe answering the door when she's home alone. Which tech tools can help Karen increase her confidence, her safety, and her independence?
I know these well. I have them at my house. First off, we can have security cameras, which can help her see what's going on. There are doorbells that she can have access to on her phone or even her television to come up so that she could have view, she could interact with the person at the door. And if it's a friend or a caregiver coming over, she has the ability to unlock her door if she gets a different type of automatic lock or keypad. And there's also automatic door openers too that she can, again, control from her phone. So it gives you a lot more security, safety, and a lot more independence with being able to interact, getting in and out of the home.
You mentioned a few moments ago about in-home services that are available for people with more advanced mobility issues, more complex needs. Can you talk us through that home evaluation process?
Sure. So as I was saying, I work in an outpatient setting, but I do have the ability to go into the home and do an assessment. When I would do an assessment, it would be pretty detailed as far as I like to make sure that we've covered all our bases in case there's future needs. So, for instance, measuring the grade of maybe a ramp or a sidewalk getting into the home. Are there steps? How high are the steps? Measuring door widths, pathways, and then throughout kind of assessing with the patient, having them show me where they have trouble areas. Maybe I've had issues where in the past it was easier to even change positions of rooms, move a dining room to a living room so that we give them better access to flow through the home, make it more open. Big areas of difficulty are bathrooms and kitchens. So, we can certainly give them the options of a multitude of options Do we need to think about getting a walk-in shower or a roll-in shower? Or can we make some modifications with equipment that they could still be able to use, like a garden tub, to be independent? And then options in the kitchen, because there's different types of counter heights. There's different ways to set things up. I've had people who maybe were in an apartment and weren't able to do a whole kitchen modification, but we were able to get a counter height table that they could kind of move into the kitchen that they easily could access, and then be able to still participate in cooking activities. So it really depends on the person, but there are plenty of options.
And are there any qualifications or criteria that someone needs to meet prior to arranging for this kind of a detailed assessment?
Not necessarily. We want to make sure that they get an assessment. If the home health therapist were to do that, they could go straight into the home, do an assessment right there, and then begin doing home evaluation. If they're looking to, they don't need a specific criteria, but when you're thinking about getting modifications, you want to make sure that they're getting a qualified contractor or someone that's very familiar with ADA accommodations, so that they'll be getting set up with the proper devices. And I always would encourage people to meet with their therapist first, because oftentimes we'll go into a home and they had thought they'd done the right thing to get this bathroom modification by getting a seat built in, but then into a shower, but then maybe the seat was too short or the grab bars weren't placed in the right place. So it's always a good idea to check with the therapist first.
Andre says he's living with progressive MS and he uses a power wheelchair when he's out running errands, but he finds it difficult to get around his older home in that power wheelchair. What suggestions do you have for Andre?
That is a tough one. A lot of older homes might have narrower doorways, narrower hallways. And so when a person is prescribed a wheelchair, actually a vendor should go to the house and see if they can get around in it. If he's moved to this new location too, it's time to have somebody come in and look again and see if there's some answers to that. There is potential to do simple widening of doorways just by using something called an offset hinge. And it can give you 1 to 2 more inches to be able to get clearance there. But again, if it's an older home with tighter hallways, it might be consideration to do some modifications. And so some measurements can be taken, and examples of how things could be improved would be a good idea.
Eric tells us he uses a mobility device and he has difficulty in and around closets and small spaces, especially when it comes to opening and closing the doors. Which home modifications might benefit Eric?
That's what we like to give options. So of course, is it an option to maybe be able to take the closet doors off completely? Can he put a curtain up instead for privacy, and it would just make it easier to go in and out? Are the shelf heights at a good spot for him so that he can reach things easily? Or if that's not an option, maybe giving him a piece of equipment that has a hook on the end of it so that he would be able to get hangers off that are up high. And sometimes it's an option to maybe get a different piece of furniture to hold some of the items that they have in their closet, or shoes or things like that. Either a skinny kind of dresser so that they can get up right beside it, or cubes, furniture with cubes, and you can push those little baskets in, make it really easy to be able to get access to the clothing and things like that.
Juanita has been living in her home for over 30 years. She says between aging and her MS, she's finding it increasingly difficult to climb the 4 stairs outside her front door. Juanita's worried she may fall at some point and is wondering whether there are options that'll make the entrance to her home a little more accessible now that her needs have changed.
There are different types. The first thing we would want to look at is if she is able to do the stairs, are there adequate stair rails? And we recommend 2 on each side. If that's not really going to be an option, we might look, and we're always thinking of the most economical option first. Are there other access ways to access the home that might be more easily modified, because 4 steps can be a lot. Otherwise, we can talk about the elevator or a wheelchair lift that actually is attached right outside the staircase that they would be able to pull their chair onto, lift themselves up, and get in and out of the home more easily.
Many people who might otherwise benefit from them are concerned about the costs associated with accessibility modifications. Does insurance cover these kinds of modifications?
It really depends on the patient's plan as to what their insurance is. And it's always a good idea to follow up and just see if that's a possibility. Other than that, there are definitely grants and assistance through the National MS Society. If you contact the navigator, they can help you steer you in the right direction if there are grants or scholarship programs to be able to
I've
help
been muted
pay for
this
those
whole time,
modifications. I've
nobody said
had
anything.
patients had
So now I
good
gotta
luck
mute again,
with
'cause now I have
getting
to
in
go
the
make lunch.
community, reaching out to their church, their
I'll be right
family,
back.
their friends, or even posting a GoFundMe to get funds to be able to make some of the modifications. But check with the insurance first. That's a good idea.
Tamara says she's interested in a home evaluation, but she lives in a rural area and isn't sure how to find an occupational therapist who understands MS. What suggestions do you have for Tamara?
Through our comprehensive care center, we definitely have a lot of resources out there. So first, try your neurologist and see if they have any recommendations for the area. Social worker can be really helpful in that as well, as trying to find someone. And if you are able to look online, there are specialists. They're listed on the National MS Society website. For instance, myself, I'm a certified MS specialist. And through the Consortium of MS Centers, they have listing of all the MS specialists in the area, in your area as well.
Are there other professionals besides occupational therapists who can provide home evaluation or consultation services that are going to be covered by insurance?
Potentially, yes. There's occupational therapists, there's physical therapists. There are some companies that are very well adapted to ADA requirements, and they will advertise that as such. So you can contact them and make sure that they're explaining exactly why they're needing to put things in a certain way. For instance, the big one is doorway widths and ramp inclines have to be a certain way, especially for if you're using a power wheelchair. You don't want to be going up a steep grade. So yes, I would look for people in the construction industry that have familiarity with their ADA requirements.
Stacy tells us that she had a home evaluation. She's already confirmed that her insurance will cover her needs. Stacy says she's ready to have the work done, but she's struggling to find a reliable professional to do the work. Are there any databases or services available to help Stacy find the right professional?
You can do a search for ADA design, and you'll have quite a few options that'll come up. There is an agency that can help, again, steer you in that direction. It'll have a list of contractors in the area to help you. It is tough, especially when there's a lot of construction going on, and it is a very specialized field. So, but it's worth it because you really want to make sure you get someone who knows what they're doing.
Cody is asking, what are some of the important questions he can ask when he calls different companies to make sure they're first reputable and also able to handle his home modifications?
Right. Perhaps ask for references, be able to ask for other pictures or of their previous work. Again, really ask them who they are involved with, if they're involved with any agencies as well that you could look into. But I agree, you do need to do your homework.
Well, thank you for sharing some really helpful information with us today. What would you say are the top 3 takeaways that you'd like our viewers to remember?
That there are definitely different ways and different accommodations and different strategies, different equipment that can keep you in your home or keep you as independent as possible so you can stay where you're at. I think another thing is don't be afraid to reach out. Like we mentioned earlier, somebody with maybe mild symptoms doesn't feel like they need rehabilitation, but it's things like these questions, like how can I be more independent in my home? How can I button my shirts more easily? How can I answer the door when I'm too tired to get up out of my chair? All those things can be really helpful, so don't be afraid to reach out to them as well. My third takeaway, that's a tough one. I might have just two.
It's all about quality, not quantity. Not a problem.
There you go.
Well, I want to thank everyone who submitted some excellent questions, and thank you, Tracy, for joining us today.
Great, thank you.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on multiple sclerosis, please be sure to visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups. You'll hear about ways that you can get involved, and you'll find out about upcoming events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Tracy for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. On YouTube, you'll find that link in the program description, and on Twitch, you can find that link in the chat. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Tracy Carrasco and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices. Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee. Currently, I'm a district activist and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect, and to connect you with MS experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your questions and comments on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering those questions and connecting you to resources. Did you know that with rare exception, you have one chance each year to make a change to your health insurance plan? The annual open enrollment period is around the corner, And during open enrollment, you have an opportunity to do your research, understand your options, and enroll in the health insurance plan that offers the best coverage for the services and medications you need at the lowest possible cost. National MS Society MS Navigator Nicole Vasquez is joining us today to explain all you need to know about open enrollment and how MS Navigators can help you find the option that works best for you. Welcome, Nicole. Thanks for joining us today.
Of course. I'm so happy to be here. Thanks for inviting me, John.
You know, being enrolled in a health insurance plan is a major step to get the healthcare services that someone needs. Nicole, maybe you can start us off by explaining what are the main sources of health insurance?
Right. So the biggest bucket of health insurance coverage comes from group coverage, what you would get as a benefit of employment or a partner or spouse's employment. Then the next bucket is going to be individual coverage, something that you would pick up on your own from, say, the marketplace. And then the last bucket is going to be government programs like Medicare, Medicaid, VA benefits, those sorts of coverage options.
What should people be considering when they choose a healthcare plan? And are there specific considerations that people living with MS should be aware of?
We definitely want people to check in on their specific needs. Things like, are your preferred doctors going to be covered? Are your medications going to be on that list of drugs that the plan covers? That list is called the formulary. If you need infusion treatment, what does that coverage look like? Another thing, are MRIs covered, and at what level?
You know, we heard from Sebastian, who told us that he lives with MS and he's on an MS disease modifying medication. He told us he's also being treated for hypertension and diabetes. And Sebastian's wondering if he needs to check the list of covered drugs before he selects the plan. And he wants to know what his options are if one or more of the drugs he uses is not covered.
Right. Definitely make sure your medications are going to be on that formulary, the list of covered drugs for the prescription drug plan for any coverage that you're considering. If you do have a medication that's not on that list, there are a variety of options that you can look at. One common restriction is step therapy. That would take some support from your doctor. And then there's also the option to appeal any denial of coverage for drugs that may not be on that formulary list.
When choosing a health insurance plan, is it important to determine which doctors are in network? And I guess more specifically, how can someone check to see whether their doctors are in network?
Right. Well, first, in network, for those of us that are like me that have trouble with remembering terminology, in network means that the plan and the provider have shook hands and agreed to work together for that year. And so what we want individuals to do, if you want to make sure that you're not only your neuro, but your primary care doctor, your PTs, anyone else that you see for medical care is in network. And what we suggest is contacting that health insurance plan specifically to see if that provider is still in their network. And also to really make sure you're checking all bases, reaching out to your providers to check with them as well and make sure that they're going to accept that plan for the next year.
Open enrollment doesn't last long, but the decisions people make over this relatively brief period of time, well, they have a significant impact on the healthcare someone's going to receive once the year begins. First, Nicole, why don't you explain what open enrollment is and then why it's so important?
Right. So open enrollment is this one time of year that you are able to re-sign or sign up for a one-year contract with your health plan. It's going to expire again at the end of the year. So you have the opportunity to continue with the named plan that you already have, or maybe switch to another option or another plan or provider even. some risks that people can look at or consider during open enrollment or facing open enrollment is just kind of letting it be, assuming that just because the plan you had last year worked, it's going to be the same thing for the next year. Plans are going to change almost consistently from year to year. And sometimes those changes you never notice and they don't impact you, but other times they can have a huge impact.
Well, thanks for mentioning some of the risks that people could face. Let's look at the flip side. What are some of the rewards for making well-informed decisions during open enrollment?
So you could end up making a change or understanding your plan better and getting better coverage. The negative, if the plan isn't going to have that same coverage or as good a coverage, you're going to be able to be prepared for any changes and that can't be avoided.
Tell me, what are the open enrollment dates this year?
So for your group coverage, those big plans, that first bucket, it's going to vary depending on the employer. Every employer is going to have a different open enrollment period. Marketplace, those individual coverages, for most states, it's going to start on November 1st and run through January 15th. But the thing to remember with that one is that if you want your coverage to start on January 1st, you have to be enrolled in your individual plan by December 15th. Okay. Also, the states that run their own marketplaces that don't use the federal marketplace, they may have a longer open enrollment period and some more options as far as those dates go. And finally, Medicare open enrollment is going to start on October 15th and end at midnight on December 7th.
Are there special enrollment periods?
Yeah. If you change employers, you'll get a special enrollment period. If you move, Medicare and a lot of the other programs will give you a special enrollment period. So life events can have an effect on special enrollment for you. The marketplace has added some subsidies. So income may allow you special enrollment periods with the marketplace as well as with Medicare. And Medicare has all kinds of fun, funky rules that can allow you to change your Medicare Advantage plan choice or opt out of something that you have chosen. But those are a lot of ifs and buts. So give us a call and we will help you look up those rules and regulations before you make a decision.
Well, I've heard you mention those marketplaces a couple of times, and Carla contacted us. She said she's moving, and she's wondering if there are some states that don't use the federal government healthcare marketplace and instead run their own healthcare marketplace. Now, I think you've already started answering this question, but hopefully you'll be able to give Carla the information she needs.
Yes, there are states that are going to run their own marketplace and have a little bit different look and rules and regulations to it. So the easiest way to figure out how to get that health insurance information is by going to healthcare.gov. There's going to be a link on there that literally says find local help. And you're going to click on that link. And you're going to put in your information for your location, and it's going to tell you where to go to look for health plans.
Dave wrote us asking, when will changes to his plan actually take effect?
Changes to his plan will take effect on January 1st in the vast majority of situations.
We heard from Jawan, who asked what happens if he changes his mind after open enrollment has ended. He wants to know if he can change his health plan selection then.
In most situations, no. Most situations, you're in that contract for the next year, but give us a call. We'll look at the ifs and the buts and figure out if you have an alternative option.
We heard from Pamela, who's wondering if she's not going to be making any changes to her current health plan. Is there any action she needs to take during open enrollment?
I would say or suggest that even if you don't plan to make any changes, we still want you to dig in to that plan and that coverage for what it's going to look like next year to make sure that even though you're not making changes, the plan isn't implementing any unexpected changes on you.
You've already brought up Medicare open enrollment a few times during our conversation, and it's important. Hundreds of thousands of people living with MS are on Medicare. So what services are offered during Medicare open enrollment?
Yeah. So Medicare open enrollment, we offer a special service starting as of October 15th and running all the way up until when open enrollment ends. We, as navigators, the Benefits and Employment Specialty Support Team is going to offer one-on-one personalized plan searches. We get together with you after we make an appointment over the phone, and we use the Medicare.gov Plan Finder tool to help you understand your options better and make an informed choice for the next year.
Who can take advantage of Medicare open enrollment? Is this something that's only for people who are already on Medicare?
Mm-hmm. Yep. So anybody that has previously had Medicare coverage can call us and set up one of these appointments, and we'll do the Plan Finder search tool with them and narrow down plan options. For individuals that are soon to be on Medicare or maybe even aren't starting their Medicare coverage until January 1st, you actually have a different enrollment opportunity right now. You have more time than this brief open enrollment window. So we will still help you and set up support for you. It's just not one of these appointments because you are not considered open enrollment. You've got more opportunity and more time than the individuals that already have their Medicare coverage in place.
While we're talking about Medicare, can you walk us through the Medicare benefit structure?
This is a fun one. Medicare is a huge puzzle with different solutions for different people. So it's good to have options, right? But it's also pretty overwhelming. So I'm gonna try and do this quick, okay? And anybody that needs more help with us, just give us a call. We're more than happy. So I consider Medicare to have three main parts. You've got Medicare Part A. Most people you'll hear refer to this as hospital coverage. I think it even says hospital on your card. It's better to think of this as inpatient coverage, okay? And then we'll skip the
fucking
big
washer's
part
probably
and
broken
go
now.
to Medicare Part D. D for drugs. These are prescription medications that you handle yourself. You give to yourself. You'll go pick up at the pharmacy, or mailed ordered and ingest into your own body, right? Anything that's not an inpatient coverage service or a prescription drug that you give to yourself, it is covered under Medicare Part B. Medicare Part B is the coverage for all medical care that's not an inpatient stay or a prescription drug that you give to yourself. So with original Medicare, with those A, B, and D, you can also pick up what's called a Medigap policy or Medicare supplement, and it kind of helps fill in the gaps in Medicare Parts A and B. And then, or you can take a completely different route and get Medicare through a privatized version. Those are called Medicare Advantage plans, or also referred to as Medicare Part C. Those Medicare Advantage plans, again, are privatized versions of Medicare, and they'll have a lot more variety to their coverage too.
Can you spend another minute, because I know this is something that confuses a lot of people.
Yeah.
Can you kind of explain the difference between what's called original Medicare and Medicare Advantage plans?
So Medicare Advantage plans are essentially, like I said, a privatized version of Medicare. So health insurance companies that we're all familiar with that will offer private insurance or group coverage will come to Medicare each year and lay out what they want to offer as alternatives to original Medicare. And if these plans are shown to have equivalent coverage, as a person would have if they just had original Medicare, those A and B parts. Then they can sell their plan as an alternative to Medicare called a Medicare Advantage plan. A lot of these Medicare Advantage plans will also tack on bells and whistles too to entice you to enroll in their policy. Things like dental coverage or gym memberships or those sorts of things to help people to entice them to come into a plan that may have more restrictions on it than original Medicare. So it's a quick summary. But what we can do with our open enrollment calls, our open enrollment appointments with individuals, is we can help you assess and narrow down those Medicare Advantage plan options, as well as if you want to stick with original Medicare, those standalone Part D plan, drug plan options.
I noticed that during open enrollment, we see a lot of television commercials, and they're all really advertising these Medicare Advantage plans as opposed to original Medicare. The National MS Society's MS Navigators can help people affected by MS navigate their way through the open enrollment period and make the best informed choices. So here's a real important question. How can people reach an MS Navigator?
So easiest way is to call 1-800-344-4867. It also is 1-800-FIGHT-MS. You can also go to our website. We have a chat feature on our website. Those opportunities are available Monday through Friday from 8 a.m. to 5 p.m. Mountain Time. Or at any point in time, you can email us at contactus@nmss.org.
And what can people expect when they contact an MS Navigator?
Sure. So one of our lovely intake specialists is going to answer your call. They're going to ask you a few questions. They're going to get you directed to the right person by asking you those questions. If you are going to call and ask for an open enrollment appointment as a Medicare beneficiary, then what they'll do is they'll transfer you over to one of our team members. And at that point in time, we will talk to you about some dates and times to set up an appointment so we can call you back and do that Medicare Plan Finder search.
Tricia wrote us asking if navigators can help people make their way through the health insurance marketplace website.
We have found that the best way to get help with that marketplace website is to go to the website that I mentioned earlier, healthcare.gov, and there is a link, Find Local Help. And with that, you can put in your location and it will come up with some options for navigators or brokers or assisters that will have specialty knowledge about the marketplace or plan options in your specific area. We also have, we also have on our website, we've set up a self-service tool and it's all about open enrollment. Give some really good documents that help you kind of look and assess and evaluate your options. And that is on our website, nationalmssociety.org/open enrollment.
Well, beyond that helpful tool, what are the ways that MS Navigators can provide assistance during open enrollment? For instance, can an MS Navigator help with a personalized plan search?
Yeah. For the marketplace, for Medicare, yes, we can do a personalized plan search using the Medicare.gov tool finder, our plan finder, and some information from you to make it more specific to you.
And that brings me to my next question. What are some things MS Navigators can't help with?
I think probably one of the biggest questions we get is from individuals that are asking for help to assess a particular health insurance company or policy based on the big open question of whether or not this so-and-so plan is good for people with MS. As we know, everybody with MS is so different as far as their personal preferences, their medical needs, their prescriptions that they're taking, comorbidities, all of those sorts of things. So what we want to do is we really want to focus on being able to answer or give a person information to be able to make an informed choice on what plan is best for you, not an overall MS answer.
Well, here's another question that I know you've already started to answer, but I'm hoping you'll share some available tools and resources that people can use to help them make the best health insurance plan decisions.
So what we have is first, again, I would go to that nationalmssociety.org page /open enrollment. That's going to give you some documents and some tools that you can use for any health insurance options that you're looking at. There's also then, once you kind of decide on what plan you want, there is another really good resource, another self-service tool on our website, nationalmssociety.org /RX help. And that's going to give you financial assistance resources and funding options and all that information for disease-modifying therapy or MS-related prescription help. And then if you need to take a step back and be able to make sure that you are accessing the right source of health insurance, we have a really good page, again, nationalmssociety.org /get covered. And that's going to give you information about all of the health insurance options that are out there.
Now, you've shared some important and very timely information with us today. What would you say are the top 3 takeaways that you'd like our viewers to remember?
Pay attention to dates. Really, this is a short time frame for us to be able to look at our options, and we don't want you to miss a chance to be able to take more control of your health insurance coverage and your health insurance over the next year. Don't assume that what you had last year can't get better or couldn't get worse. Ask questions and check in on those benefits just to make sure that you're understanding what you've got there as options. Honestly, the last one, don't feel bad about being intimidated. Don't feel bad about getting frustrated. No one has a crystal ball to be able to say what you're going to need or what medical interventions may be necessary in the next year. And so we want to help you understand and be there to help you to make an informed choice about what coverage could look like for you next year.
Well, thanks for sharing your expertise with us, Nicole. I think we have time to handle a couple of additional questions from our audience.
Okay.
Brianna wrote that she was hired 2 months ago and she signed up for health insurance with her new employer. Now Brianna wants to know if she has to do all of this again next year.
Brianna, sorry. Yes, you will. It may not be as difficult because you already have that foundation of knowledge about what your employer's health insurance plans tend to look like. But yes, you do need to double check and make sure that you're assessing your options and making an informed choice for next year.
We heard from Maria, and Maria told us she doesn't have a computer and wonders if there are other ways that she can enroll in Medicare.
Yes, absolutely. So once you decide on what you want to do for your coverage, there is the option or opportunity. You can contact Medicare.gov and they can enroll you over the phone. You can use a broker. Many brokers and insurance agents across the country have the ability or will enroll individuals. You need to make sure that broker is going to have access to the policy that you want to sell it. And you can also contact your local SHIP, which is your state health insurance assistance program. And the SHIP information is on the Centers for Medicaid Services website at cms.org.
Ronald contacted us and he wants to know if he can get Medicaid if he has MS.
Yes, he could. But Medicaid is not going to be the only. Certainly, you can give us a call and we can talk more about it. Probably the best way to determine if you'd be eligible for Medicaid in your state, because it is a state-specific program, is to contact your Medicaid office and get the information from the horse's mouth.
Well, I want to thank everyone who submitted questions, and thank you for being with us today, Nicole.
Yeah, of course. Thank you.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. And as Nicole mentioned, you can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on MS, please visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups. You'll see ways that you can get involved, and you'll hear about upcoming events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Nicole for joining us today.
My wrist is
Please
doing its
remember
weird
that a
shit
recording
again.
of this webcast will be available at the Society's website at nationalmssociety.org/
Making it hard for me to fucking work.
MSExpert, as well as on Facebook and YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Nicole Vasquez and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.
I don't want to.
Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect, and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering those questions and connecting you to resources. As we get started, I'd like to acknowledge and thank today's contributing sponsor, Sandoz. Support from MS community partners helps the National MS Society reach its goal of providing up-to-date information and support through programs like Ask an MS Expert. Evidence shows that disease-modifying therapies, or DMTs, can reduce the number of MS relapses, delay the progression of disability, and limit new activity as seen on an MRI scan. And as most, if not all of you know, these medications can be incredibly expensive. But now, more affordable options are becoming available in the form of biosimilar and generic medications. Joining us to help us better understand what biosimilars and genetics are, the differences between them, and their role in treating MS is Dr. Jiwon Oh. Dr. Oh is a neurologist, scientist, and the medical director of the Barlow Multiple Sclerosis Program at St. Michael's Hospital in Ontario, as well as an associate professor at the University of Toronto. Welcome, Dr. Oh, and thanks for being with us today.
Thanks, John, for the kind introduction, and thank you for having me.
To get us started, can you explain the similarities and differences between a generic and a brand name medication? And I hope you'll share some examples of brand name disease-modifying therapies that have a generic available.
Sure. Essentially, generic and brand name medications are compounds, chemical compounds that act in very similar ways from a clinical standpoint, but they're not exactly the same chemical compound. And essentially, in clinical care, we see this because it takes many, many years for pharmaceutical companies to develop a medication and test it in people living with MS. And so at a time when a medication is approved, that company has an exclusive patent on that medication. And there's a certain time frame in each area of the world where companies have patents for a specific medication. And when that exclusive patent runs out, other companies can manufacture similar chemical compounds that have the exact same active pharmaceutical substance, but there may be some inactive ingredients that are a little bit different from the original patented drug that was the one that...
This term I'm going to ask you about isn't quite as common. What are the similarities and differences between a biologic and biosimilar medication? And again, I'm hoping you can share an example of a biologic that has a
brand name and generic medications in MS. So in recent years in the MS field, we've seen a number of generic medications emerge. And so examples are, we have oral drugs like, say, Gilenya, which was first made widely available in 2010. And in recent years, we've seen a number of generic compounds emerge. And the active chemical substance in each set of generic forms of Aubagio emerge. Concept is very similar to what we biologics. These are biological substances, so they're different from the simple chemical compounds that are generics. And so these are all pretty complicated molecules that include organic substances. And so the whole kind of generics and brand name pharmaceutical compounds. And so the difference really is in that biologic substances tend to be much more complicated. And so there's an entirely different regulatory process when it comes to approving biosimilar medication. Brand names are simple chemical, are the analogy of that, but just much more complicated biological molecules. And some very, very recent examples in the MS world of the body that was approved, which is Tyruko. So this is a biosimilar medication that where there have been clinical studies are very...
That's what I take.
The similarities.
Similarities are name molecule, but essentially are clinically very similar to the reference product or to the original brand name molecule. And so there are biosimilar realm disease. Molecules from a clinical standpoint should be almost indistinguishable from the parent compound, which is what we want because we're looking for drugs that have a very similar effect clinically to a drug that we've known for a very long time and are familiar with the efficacy as well as the safety of a drug. But usually the benefit of having either a generic or a biosimilar is
biosimilar
in terms of chemical structure and always a little more complex.
I actually think medications are made differently. Can you tell us about those?
Thing to note with the approval process is that it's entirely different. It's an entirely different pathway from a regulatory standpoint when looking at the approval of a generic compound versus a biosimilar compound. And again, this just has to do kind of relatively simple chemical products. And so there are a number of additional components in the regulatory process that biosimilars need to demonstrate. And so it's pretty strict, and actually an entirely different division of the FDA because of the complexity related to manufacturing biological products.
Why might a person living with MS switch from their brand name medication to a...
There are many different reasons, but probably the most common reason is anytime a generic product becomes available, and now we'll get drug cover, sort of healthcare policies you have. And even within a country, it differs depending on, say, what part of the country you live in, because the rules and availability of different coverage system is a move to switching from either the brand name or the reference product to a generic molecule or a biosimilar, because typically the cost tends to be a bit lower. So this is really the most common reason. However, because these are also similar products that, you know, from a clinical standpoint, behave in a very similar way, these are not actually identical products. And so there are inactive chemical substances when it comes to generics or biosimilars that are slightly different from the brand name molecule or the reference product. And so everybody can react a little bit differently to some of these chemically inert substances. And so it may also have to do with tolerance, as well as you know, kind of personal things like that that may make one want to switch from one version of a pharmaceutical compound to another.
People are more likely to adhere to a treatment plan if they've had a voice in creating it. What kinds of things should someone living with MS consider when they're participating in shared decision-making with their doctor about their MS treatment?
So, you know, I think the most important thing is that regardless of whether you're thinking about generics or a biosimilar or compound, there is very clear evidence in both of these settings that compound behaves in a very similar way from a clinical efficacy as well as safety standpoint to the original molecule. And so I think before switching to, say, a generic or a biosimilar compound, people living with MS should ask questions like, should you expect to see a difference in terms of disease measures? Should you expect to see a difference in terms of how a medication is tolerated? Are there any additional safety concerns or anything else like that you need to be aware of? So I think, you know, all the right questions should be asked and answered. And then people living with MS should also probably keep track of any differences that they notice on a day-to-day basis as they're switching over to the new molecule. And then obviously with your neurologist, you should be mindful of measures of disease activity as well. Like at your annual visit, is there any suggestion of change in comparison to the drug that you were on before with respect to whether you've had relapses or any new neurological symptoms, or whether your MRI activity has changed? So I know it's a lot to unpack, but it's probably just making sure you feel comfortable in making the switch and then knowing what to look out for.
Well, one of our viewers is asking one of the questions you just mentioned. We heard from Allie, who tells us she's living with MS and recently started taking a brand name medication that she says is working well for her. But recently, she had a negative reaction and developed hives. And Allie is wondering whether switching to a biosimilar or generic might be an option for her.
I mean, I definitely think it's an option. It's hard to say what exactly was the part of the chemical compound that caused the hives, whether it was actually the chemically inert substances or if it was the clinically active substances. And so because we never quite know what the inciting antigen is for an allergic reaction. If this is a drug that otherwise Ali is happy with and satisfied with, it may be worth considering a generic option in this setting, just because it could be one of the inert substances that is causing the hive reaction.
Jamie says she recently switched to a generic version of her brand name DMT, and she wants to know whether she should be worried about its safety or efficacy because of the difference in the approval process or how it was actually manufactured.
So, as we've talked about earlier, John, I think anytime there is a switch, it is important to be vigilant and monitor symptoms. But I think that Jamie can be reassured that with the approval of any generic compound, again, there's pretty strict criteria that the compound needs to meet in terms of demonstrating chemical similarities to the parent compound. Particularly with respect to the clinically active substance. So that substance has to be identical. And then there are some chemically inert substances that are included in the process of, say, manufacturing a tablet that may be relevant in terms of tolerability. So from a general clinical efficacy as well as a safety standpoint, there needs to be clear demonstration in a phase 3 clinical trial that it's nearly identical to the parent compound. So Jamie can probably be reassured about those points. However, because of the slight differences in the chemically inert components of the drug, it is worth being vigilant about tolerability issues, as well as in the longer run, monitoring to see if there are any additional safety issues.
As we've been discussing, biosimilars are made from living sources, which result in natural variations between batches. And we've heard from Lori, who tells us that those inconsistencies from one batch to another, they make her nervous about changing her MS treatment to a biosimilar. Is there any evidence-based information out there to support Lori in her decision-making?
So, Lori's correct in that because biologic substances are much more complicated, there is inherent variability with living substances. And this is actually to be expected. Even with, say, the reference product, and in this setting, we'll just use Tysabri as an example. In different batches of Tysabri, because they are biological substances, there is expected variation. However, there's a certain amount of expected variation, and this is pretty tightly controlled. And then when there's more variation than what is to be expected from within even, say, the same batch of Tysabri, this is when this is a problem. And so, I think it's important to keep in mind that variation is the rule when it comes to biological compounds. And so again, even in a batch of Tysabri, you will expect to see variation and between batches of Tysabri. And so this is to be expected that there is some inherent variation when it comes to biosimilars as well. However, the magnitude of variation is pretty tightly controlled, and when something deviates from outside of the expected norms, then this is thought to be unacceptable, and this is when a biosimilar would not be considered the same as the reference product.
Hector's partner has relapsing remitting MS, and they're hesitant to consider a biosimilar because they've only started hearing about them recently. How long have biosimilars been around, and what other diseases are being managed with them?
So biosimilars are something that's relatively new, I guess we could say, within the pharmaceutical space. But there are a number of biosimilars that have been around since 2015. So 2015 sounds pretty recent and used to treat many different disease states. An example that might be familiar to some people with MS includes rituximab, which is a monoclonal antibody that is not necessarily approved for use in MS around the world, but it's because it's such a similar molecule to Ocrevus or ocrelizumab. It's used in many parts of the world, sometimes even preferentially. And there's many different biosimilar versions of rituximab that have been used in MS and for many different inflammatory diseases around the world, including for pretty common diseases like rheumatoid arthritis and lupus. So all of this to say, in the MS sphere, just because we have the first biosimilar that's been manufactured, Tyruko, and this was literally days ago approved by the FDA, it seems new. But just want to reassure people that in many different disease states, biosimilars have been used for nearly a decade.
Madeline tells us that she picked up her MS medication and she was surprised to find that she was handed a generic rather than the brand name that she normally receives. Can you explain what automatic generic substitution is and how it might impact someone living with MS?
So this is something that happens pretty commonly with generic compounds when they become available. And it does differ based on where you live in the world, as well as even across different states in the United States. But pharmacists often have the authority to substitute a brand name compound for a generic compound in many different states. And this does not necessarily require sign off from the treating physician. And this is, again, because I know, during this session, we've talked a lot about generics and brand names and biosimilars and biologics. And there are differences with respect to substitution. But because generic molecules are usually simple, that pharmacists often are able to simply substitute the generic compound for the brand name molecule.
So now that this has actually happened to Madeline and she's starting this generic for the first time, is there anything that she should be tracking now that she's been switched?
I think as we talked about before, definitely she should talk to her neurologist about it, ask any questions she might have, and be reassured that in general, there are very clear clinical trials that need to demonstrate clinical efficacy as well as safety that's comparable to the original brand name molecule. So Madeline should be reassured about that from her neurologist. But just keep in mind that even with pretty simple chemical substances like brand name molecules and generics, the pharmaceutically active molecule is identical, but there are inactive components of the drug that are slightly different between the generic and the brand name molecule. And everybody reacts a little bit differently, even though these compounds are supposed to be chemically inert and not have an effect on the disease itself. Everybody can have different tolerability of these chemically inert substances. So probably just keep a diary, keep track of bothersome symptoms if she has them, and these are things that should be brought up to the neurologist when she sees her doctor.
We've been talking about biosimilars replacing a biologic reference drug, but I'm wondering whether a biologic can be substituted for a biosimilar medication. Why or under what circumstances might a treatment be deemed interchangeable or not? And are there any specifics a person with MS should consider in these situations?
So, John, I think a theme is emerging from many of our discussions today. When it comes to the biologic world and the biosimilar world, everything is just more complicated. And this is, again, just related to the fact that biologic molecules are just much more complicated and they're much more intensive to manufacture and store and all of these things. And so because of this, this is actually distinctly different between generics and biosimilars in that pharmacists normally cannot just switch from the reference product to the biosimilar is deemed to be interchangeable with the reference product. And by way of illustration, there's over 40 different biosimilars that have been approved widely for use around the world, and only 3 of them have been given that, probably coveted designation of being interchangeable with the reference product. So only in that setting, and in order to be deemed interchangeable, you have to meet very strict regulatory criteria. Only in that setting is when a pharmacist can substitute the reference product. So in the MS world, that would be Tysabri for the biosimilar, which is Tyruko. And again, this is only if it is given this very special designation as an interchangeable molecule.
You shared some really important information with us today, and very timely information, as a matter of fact. What would you say are the top 3 takeaways that you'd like our viewers to remember?
So I think we're kind of stepping into an era in the MS treatment field where, obviously we're very fortunate because in the last, 15 years, there's really been an explosion of the number of treatments that we have available. And we're now, in the last number of years, stepping into an era where there are many generic molecules emerging, and now, for the first time, a biosimilar emerging. And so I think this is something that people living with MS should be aware of, just because it will happen where there is a suggestion of a change from the brand name to the generic. Aware of this. Be prepared to ask the right questions, and then be prepared to monitor symptoms, and then talk with your neurologist if there's concerns as some of these switches are happening.
Well, I want to thank everyone who submitted some excellent questions, and thank you, Dr. O, for joining us today.
Thank you, John.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on MS, please be sure to visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups. You'll hear about ways for you to get involved, and you'll find out about events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and link start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Dr. O for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSExpert, as well as on Facebook and on YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Dr. Jiwon Oh and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices. Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering those questions and connecting you to resources. Intimacy and sexuality are important components of a happy and healthy life.
Yeah, they are.
And although MS can affect sexual feelings and responses,
Yeah, it can.
sexual intimacy does not have to disappear when one partner is living with MS. Madeline Esposito is joining us today to discuss some of the common sexual problems faced by people living with MS, along with treatments designed to resolve those problems, ways to maintain intimacy in your relationship, and tips for a healthy sex life. Madeline is a mental health clinician at the University of Wisconsin Health's Behavioral Health and Recovery Clinic. She's a certified sex therapist and a clinical adjunct faculty member at the University of Wisconsin School of Medicine and Public Health. Welcome, Madeline, and thanks for being with us today.
It's my pleasure.
Some people avoid discussing sexual problems because either they're embarrassed or they don't realize that those sexual problems could be related to their MS. So I hope you'll take a moment to explain the role sexuality plays in our lives and why it's important to address these kinds of problems as we would any other MS-related symptom.
Studies routinely show that sexual health correlates with satisfying relationships and just overall well-being. We are sexual beings from womb to tomb, and it's the culmination and intersection of multiple domains of our lives. And it influences our ability to not just connect with other people,
this
but
woman
just
is the
even
equivalent
ourselves.
of like the Eva Mendes at-home version.
Can you explain how MS directly affects sexual feelings and function?
Absolutely. So the central nervous system, the CNS, it makes sexual arousal possible. The brain, sexual organs, and other parts of the body, it sends messages to each other along nerves that run through the spinal cord. MS-related damage to these nerve fibers can directly impair sexual feelings or sexual responses in the same way that damage in the CNS can affect a person's ability to walk or see. And just as with other aspects of MS, sexual problems can arise at any time.
What kinds of sexual problems are the direct result of MS-related damage to the nerve fibers in our central nervous system?
Some of the problems that someone could expect could decreased vaginal muscle tone or difficulty or an inability to get an erection, as well as decreased vaginal lubrication and clitoral engorgement, difficulty with or inability to ejaculate, and decreased frequency and or intensity of orgasms.
So are there treatments available for people who experience these kinds of sexual problems?
Yes, so sex therapy is incredibly useful to explore options of enhancing sexual satisfaction and then discussing behavioral interventions. I like to explain what sex therapy is. There's different ideas of what exactly it looks like in practice. It's a specialty of psychotherapy that addresses sexual issues and it promotes empowerment and pleasure. And I don't use any examinations. I never touch my clients. It's strictly talk therapy and then making recommendations that they can try at home. We also collaborate with other health professionals and can assist as well in articulating the most sensitive sexual health concerns to your care team. In addition to sex therapy, openness and sexual flexibility improve sexual health as well. So delegating physical labor with the use of sexual aids can be incredibly helpful regardless of anyone's physical limitations. And these might even include wedges, pillows, vibrators, dildos, and water-based lubricants.
Well, we know that MS symptoms can sometimes interrupt everyday activities. What are the most common MS symptoms that impact sexual feelings and function?
Yes, fatigue, pain, spasticity, bladder, bowel changes, depression, and cognitive changes are the major ones.
We heard from Jenna, who experiences terrible fatigue, which makes sexual activity feel overwhelmingly exhausting. You have any tips for Jenna?
Yes. So fatigue is a major inhibitor for even interest in sex. Typically, I recommend scheduling sexual activity. And even though usually people have a hard time with the idea of scheduling sex, it can be incredibly helpful to dedicate time where people can really feel their best. So activities that result like in more fatigue or cost spoons, as many people describe them, they could be limited on days that someone plans on initiating sex. And honestly, I push back against the idea of spontaneous sex anyway, given how many of us prepared for our first date. You know, thinking about we went out and we likely took a shower before we went out with that new prospective partner. So I do push back on the myth of spontaneous sex. I think it's also helpful to remember that sex can have intermissions and does not really require penetration to be enjoyable. And I also really do appreciate delegation of having sex toys as well to alleviate additional work.
I have no idea what this fucking.
We heard
image
from
is.
Mark, and Mark told us that he experiences pain and spasticity, which interfere with sexual positioning and pleasure. What can Mark do to improve his experience?
With partnered sex, communication of what feels good and not so good is key. I think a lot of people struggle with articulating how they're feeling and what feels good and not so good for themselves. Massage is a great method of relaxing those muscles,
Yeah,
and
don't
it also
shove
would
things
inform
without
Mark's
lube.
partner of where he
Hurts.
feels the most spastic. On
That
high
can cause a big
spasticity
problem.
days, he may also opt to lay down and have his partner on top or take the lead with stimulation as well.
Denise says she has bladder problems and struggles with leakage, which can make sexual activity very embarrassing. So now she finds that she wants to avoid it. Is there anything Denise can do to prevent bladder accidents from happening during these intimate moments?
Absolutely. So I'm back to scheduling sexual activity, which really does help reinforce good behavioral interventions that lower the risk of leaking. So interventions like emptying her bladder beforehand, using waterproof sheets. Rubber is great because it doesn't make much noise unless someone has a latex allergy. Avoiding positions that place pressure on her abdomen. Also like avoiding caffeine and alcohol. One other option as well is to ease into sexual activity by having sex or engaging in sexual activity in a shower or a bath where leakage is not as noticeable.
Rachel is wondering if the side effects of her medication are affecting her sexual desire and performance. What types of medications can affect sexual feelings and function?
Full disclosure that as a sex therapist, I don't speak medication. So typically what I recommend for my clients is to initiate conversation with their prescriber about sexual side effects. Many providers don't prioritize disclosing this information, and sexual side effects can come along with many of the medications that we regularly use. And so simply like timing can be really helpful. Cleveland Clinic, for example, recommends. So if medication is required, going back to the prescriber, asking more questions about side effects, as well as timing of when that medication could take place.
Living with MS can take a toll on your physical and your emotional health. And some people may not feel interested in sex simply due to the stress of living with MS. We heard from Chantel, who lives with depression, which is a common MS symptom, and she never feels in the mood to be sexual with her partner. How do mood changes like depression, anxiety, and grief affect sexual health? And what can people do to manage those mood changes?
This is something as a sex therapist I see every day, and I remind my clients that sexual desire is systemic, meaning that desire is impacted by biological, psychological, and sociocultural factors. Many mental health conditions affect sexual health, and oftentimes it's the first indicator that something is amiss. Depression is an excellent example of this, as it comes with anhedonia, the lack of interest in enjoying pleasurable activities, as well as fatigue
Oh, see, the fact
and
that I was
poor
never
messages
really
about
like
oneself.
worried
And
about
these are
having
all
sex could have been an
biopsychosocial
identifier
concerns
that I had
that
MS years
can
ago.
and will inhibit desire.
Yeah, because that would have been a fun conversation.
Sexual
for
desire is
everybody.
also affected by anxiety, obsessive compulsive disorder, trauma, and ADHD. Oftentimes, just simply treating and managing these conditions will indirectly improve sexual desire and then shift any of the relationships affected by the mental and sexual health component.
Luis tells us that he uses a wheelchair and his wife is his care partner. Being physically dependent on his wife for things like getting dressed and getting in and out of bed makes it difficult for Luis to want to be intimate, and sometimes he physically can't. Do you have any advice for Luis and his wife for how they can reclaim their sexual relationship?
I don't think it can be understated how chronic conditions affects relationships, and I don't think enough people talk about it. Many folks describe feeling infantilized as though their partner is the parent and they are the child in need of taken care of. And this is a recipe for lower desire in both partners and can result in lost intimacy. Some of my recommendations include dedicating time to go on dates without any expectation of sex, but also introducing erotica and or sexual aids that can reignite that interest and then change the typical routines.
Buy your woman
One
a
other
rose.
helpful option is couples therapy, where they can work on communication and creating more distance in their relationship to foster desire.
Just as in so many other areas of life, communication is really the first step to getting your sex life back on track. But discussing personal sexual problems or preferences can feel awkward or uncomfortable. What are some tips for how partners can start talking about these sensitive issues in an open and honest way?
I appreciate conversation starters like books on sexual health that you can even accidentally leave on your nightstand, like Come As You Are by Emily Nagoski. A new one for me is Speaking from the Heart by Anne Hoddership. Sometimes the couples I work with start with simply sending a text message or writing a letter or an email to begin that conversation and provide their partner some space to consider a thoughtful response. When discussing sex, I find it helpful to walk and talk or converse while distracted, and this usually helps to lower someone's guard.
Why is communicating with your healthcare team about any sexual problems you're experiencing so important? And who should be included in those conversations?
Sadly, many
Sometimes your
medical
lips do get a little
professionals
bit
struggle
bigger,
to
yeah.
initiate conversations about sex
But it's not
based on their
guaranteed to
own
happen.
discomfort, their own
'Cause
concern
not
about
everybody
not
has the same
having
lips.
enough sex
People don't
education
always
to
grow the
answer
same.
any questions that arise. And some providers also look at sexual health as a bonus. Clients need to do their own sexual self-advocacy and
my
ask
lips aren't that big.
questions and mention the sexual problems that are going
They
on.
shrink.
It's important to ask about sexual side effects for medications,
Right.
options should the sexual
Here's
side
silly
effects
girl.
be significant, sexual side
Yeah, not
effects for
everybody has big
procedures they
lips.
may have, maybe
But it makes you look funny.
undiagnosed.
Makes you look like a baboon butt.
Alex says he and his husband have talked about their sexual problems, but they aren't making any
Yeah, it
progress.
makes you look like a baboon butt.
A few moments ago, I heard you talk about sex therapy, and Alex is wondering if he should
They can
reach
be,
out
yeah.
to a sex therapist. So how can a sex therapist help people who are facing sexual challenges, and what kinds of things should someone consider when looking for the right therapist for
everybody's
them?
different.
Sex therapists are excellent at providing sex
You
education.
don't even know what
and
you're gonna look like
space
until you
and
spend your time
certified
enjoying
in the
being a
American
kid.
Association of Sexuality Educators, Counselors, and Therapists, or ASECT. We have a rigorous
He's-
certification
does-
process
does he need
and
food?
are
Is
equipped
his
to
sister
use
locked in your room?
evidence-based approaches.
Great information with us about an aspect of living with MS that probably isn't discussed nearly enough. What would you say are the top 3 takeaways that you'd like our viewers to remember?
I think shifting your mindset on sexuality. There's no such thing as normal or typical sexuality. Healthy sexuality is individualized and based on preferences and abilities. A second takeaway, acknowledge all inhibitors for desire and celebrate the factors that really do foster connection. Desire is systemic, so multiple factors can help or hinder us. And then also considering the importance of communication and sexual self-advocacy. These are absolutely essential for sexual self-esteem.
Well, thank you for sharing your expertise with us, Madeline. I think we have time to answer a few more questions from our viewers of aging and menopause.
This is a common predicament. Which condition is causing the sexual problems? Thankfully, the interventions previously discussed, these will help should either condition be the culprit. With menopause, I do recommend connecting with a great OB-GYN to discuss medical options to minimize effects, especially those in regards to vaginal atrophy
What
and
are
the
you
use of
doing?
moisturizers.
Bring him to the living room.
Judy says Judy rediscover her sexual self.
That's a big question. So my first recommendation is to have an examination to rule out any complicating factors, like vaginal atrophy if the vagina hasn't been used, pelvic pain or tightness that would warrant a referral perhaps to pelvic floor physical therapy. If there is a partner involved, I also recommend seeking a couples or sex therapist should there be concerns about communication, especially given how sensitive sexual health issues are. It can be quite difficult for even the most skilled couples to talk about. Regardless, the brain is the largest sexual organ, so creating space to consider sex can be just enough to increase curiosity.
Michelle tells us that she's not on birth control because of several other medications that she has to take, and she's worried she may get pregnant, so she avoids sex, even though she knows it's hurting her relationship. You have any advice for Michelle?
This would be a great topic to discuss with her partner, specifically his, her, their expectations and flexibility with expanding the definitions of what sex is beyond vaginal penetration. Again, we're back to communication as vital, and it's important to clarify expectations or sexpectations.
Submitted some excellent questions, and thank you, Madeline, for being with us today.
Thank you for having me.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on Living by Chat. For information and dates and news, information on connection programs like self-help groups, you'll hear about ways to get involved, and you'll find out about the upcoming events that are taking place by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at realtalkms.com, Apple favorite podcasts. I'd like to thank Madeline for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. I hope you'll join us for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Madeline Esposito and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices. Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, and Twitch. MS Navigators are online throughout today's program, and managing your pelvic floor health may not be the first thing on your mind. But pelvic floor dysfunction and the problems that relate to it, like bladder and bowel issues, Positive and Mean Crowd is joining us today to explain the important role. Jill's going to share some strategies and insights designed to empower you on your path to achieving a healthier pelvic floor. Jill is a physical therapist and a women's health men and children. Well, let's start with why are they important?
Yes, so the pelvic floor is a group of muscles that sit at the base of the pelvis, and they really have three kind of main jobs or functions. So this would be the bladder, rectum, colon, stomach from the bottom up. Number two, they do have a sexual function. So they function in erection, both in males and females, and also function very much so in bowel and bladder control. So I kind of think of it like a clamp on a hose. They surround the urethra, which is the tube that carries urine from the bladder outside of the body, acts all the way to be able to go to the bathroom.
So what is pelvic floor rehabilitation, and how does it help manage symptoms related to MS?
Yeah, so pelvic floor rehab is physical therapy for your pelvic floor muscles. You know, they're muscles just like anywhere else in the body, and unfortunately can be affected by MS. So we first start by assessing the individuals with MS. That tends to be more the case, but they can be both at the same time. So by going through pelvic floor rehabilitation, we help the muscles really function the best they can. And because they have such an important function in bowel and bladder control and keeping you dry, but also being able to go to the bathroom, by getting the pelvic floor to really function optimally, we can help decrease any bowel and bladder issues that might be present.
Can you tell me about specific techniques or exercises that are typically included in a pelvic floor rehab program for people with MS?
Yes, well, so physical therapy exercise obviously is kind of the first thing we think of. One really important exercise that most people have heard of and probably never done is called a Kegel. That's basically just contracting and relaxing your pelvic floor. The interesting thing about Kegels is research has found about half of the people aren't doing them correctly, whether they're squeezing on their muscles or pushing down rather than squeezing up and in. So by working with a pelvic floor therapist, we make sure you're doing that the right way. Whatever other muscles might need work, so maybe core strengthening, hip strengthening, or even coordination types of exercises if the muscles are too tense, to kind of teach the muscles how to relax. One tool I have to help with coordination is called biofeedback. So it's surface EMG. We put little electrodes on your bottom and then hook you up to the computer, but it kind of looks like a heart rate monitor for the pelvic floor. What's really nice about that is you can't see what your pelvic floor is otherwise doing, so it's kind of hard to learn how to control it. So by doing the biofeedback, you can actually see, in my clinic, I have it on my nice computer screen. You can see it, so that helps improve the connection between the brain and the muscles and helps with control for that.
Well, we've heard from Mary, who's wondering if there are potential side effects or risks that individuals with MS should be aware of when they're undergoing pelvic floor rehab.
Yeah, so that's kind of the nice thing about physical therapies. There really aren't that many side effects or risks with it. One side effect possibly is, so say we're working on a lot of maybe strengthening types of exercises, you might be a little bit sore for a few days. That wouldn't be any different than if you're starting a new exercise routine and doing different strength type of exercises where your muscles might get a little bit sore, but that will go away over time. I also like to do a lot of hands-on manual therapy through muscles that might need it, including the pelvic floor. And again, sometimes patients might be a little bit sore the first couple times we do that for a day or two, but it's something that goes away. So really, besides maybe some minor soreness for some people that's short-lived, that's the nice thing about PT is there really isn't any other side effects with it.
Well, I think you've already started answering the first part of my next question. I was going to ask you, how does pelvic floor rehab contribute to the overall quality of life for individuals with MS? And with regular rehab sessions, how long does it usually take to see improvements in pelvic floor function?
Yeah, so first part of the question, you kind of talked about this a little bit in the intro. Until you experience maybe bowel or bladder issues, you really don't know how much it can affect your quality of life. So how many times I've heard patients say, I know where every bathroom I'm in Fargo, I know where every bathroom in Fargo is, in this store, this restaurant. I always come with a change of clothes, things like that. It really can affect your quality of life. So by working with pelvic floor therapy, because it affects bowel and bladder function so much, we can positively impact some of those quality of life issues where you can go out for supper maybe and not have to go to the bathroom a couple of times or pack a change of clothes. So it really does positively impact the quality of life of these patients. Second part of your question, we usually want to see some degree of symptom improvement within about a month or so. Most of my patients I'll see once a week, sometimes twice, kind of depending on what we need to do. We will most likely start to see changes in strength and maybe muscle coordination and things like that within a couple weeks. But to see symptom improvement, so maybe bowel and bladder changes, can take a month. But that's just starting to see changes. Usually 3 to 6 months of being kind of consistent with exercises is what we're looking at to really get the maximum improvement out of this.
So what would you say are the long-term benefits of incorporating pelvic floor rehabilitation into a comprehensive management plan for someone with MS?
Yeah, unfortunately for a lot of individuals with MS, it's progressive disease that tends to get worse over time, and that does not discriminate against bowel or bladder issues. Constipation might get worse over time. Feelings of emptying your bladder might get worse over time. So by starting a pelvic floor rehabilitation program, we can keep the muscles functioning as best we can over a long period of time. By trying to maintain or restore muscle function as early as we can, that can maybe slow some progressive effects of MS. It might even make it so down the road some progressive effects might not be quite so severe because the muscles are already functioning that much better, that we might be able to slow some of those processes that might happen down the road.
Well, this has been a great overview. Let's drill down a little bit further. How does MS specifically affect the pelvic floor in women, and what are some common related symptoms that might be experienced by women who are living with MS?
Yeah, so we're going to typically see one of two things with the pelvic floor, and actually we can see both at the same time, honestly. A lot of times the muscles will become weak, and that can lead to maybe some more bladder, bowel, incontinence, leakage types of issues. So again, the pelvic floor clamps down on the urethra or the anus. I'd liken it like a clamp on a hose. The stronger it is, it can clamp the urethra shut and you won't leak urine. When they're not as strong as we want it to be, that hose isn't clamped all the way shut and we might experience some leakage or incontinence issues. What we will see more often than not in patients with MS, muscles usually are weak, but they're also over tense. We kind of call it overactive. They can't relax the way we want to. They're kind of stuck in a contraction all the time. This sometimes will present a little bit different with bowel and bladder issues. This can contribute to constipation, which we'll see a lot in these patients. The pelvic floor surrounds the anus, so it needs to be able to relax the way we want it to allow you to have a bowel movement. When the muscles don't relax very well, it's kind of like you're trying to have a bowel movement through a closed opening, essentially, and that can make constipation issues worse. With the bladder, because the bladder sits right on the pelvic floor muscles, when they're tense, they'll push up on the bladder, they can irritate it a little bit, and that will cause urinary frequency, so you're going to the bathroom more often than you should. Feelings of urgency, like you need to rush to the bathroom, you're not going to make it in time. Also, feelings that you're not emptying your bladder all the way. Because again, clamp on a hose, I use that a lot. But if that clamp can't relax all the way and open up, urine isn't going to flow out as easy as it normally should. So those are going to be some of the things we'll see more often than not.
How can pelvic floor rehab help manage menstrual-related pelvic pain or discomfort in women with MS?
So a lot of times kind of menstrual pain will come from the uterus itself. That'll cause some discomfort. A natural response of our muscles is to kind of tense and guard against pain, which when you think of it like you touch a hot stove and you pull away, that's what we want. But when it comes to other issues, so say you're having menstrual pain and your pelvic floor tenses because of that we maybe don't necessarily want, because now we're going to have tight muscles on top of it. And just like muscles that might be tight, so say your low back, or if you have tight muscles up here that cause headaches, that can cause more pain. So when the pelvic floor is tense and tight, guarding against that pain, we're going to have muscle pain on top of it and make things worse. So pelvic floor physical therapy in that instance, we're going to focus more on relaxation types of exercises, stretching types of exercises, some hands-on soft tissue releases through the pelvic floor and even the lower abdomen to get those muscles to kind of relax and let go. And that can help decrease pain-related issues.
Jada recently had a baby. and was just diagnosed with pelvic organ prolapse, a condition where the organs inside your pelvis drop or fall and are sitting lower than they should. How can pelvic floor rehab help with postpartum pelvic floor issues in women with MS?
Yeah, so kind of like earlier, the very first question, one of the functions of your pelvic floor is to help support all of those organs. So during pregnancy and childbirth, and this can be vaginal or a C-section, your pelvic floor has been working extra hard for 8 to 9 months, let's say, on holding a baby and all of that. So they're kind of tired and not as strong as they should be. And because they support those organs from the bottom up, when they're not as strong as they should be, the organs are going to drop a little bit. And that's when we can get prolapse. So by strengthening through the pelvic floor, we can help support those organs from the bottom up, and that can help improve pelvic organ support with a prolapse, and also any other symptoms that might come along with that.
Are there specific exercises or lifestyle changes that have been proven effective in strengthening the pelvic floor muscles in women with MS?
Yes, absolutely. So number one is going to be Kegels. That's really just contracting and relaxing through the pelvic floor. You know, it's just like doing even a bicep curl to strengthen your bicep, a contraction exercise anywhere else. Kegels are kind of the bread and butter in strengthening the pelvic floor. I also like to do a lot of hip strengthening, so sometimes squeezing a pillow between your knees or pushing your knees out against a band. By strengthening your hips, it has been proven actually to kind of overflow into the pelvic floor and improve pelvic floor strength. Also a lot of core strengthening because all those muscles work together. So I'm improving strength in one, so say core strengthening, we're going to improve strength in the pelvic floor as well. And there are lifestyle changes that are fairly, I think, pretty easy to implement that can help improve bladder function. So number one that we see a lot is making sure you drink enough water. A lot of patients with bowel and bladder issues actually cut back on their water because they think it's going to be helpful. You don't have to go so often, you might not leak, things like that. But actually, when you're not drinking enough water, the urine that is in your bladder becomes a little bit more concentrated. So we've all seen it before. Well, I'm weird and I look at the color of my urine, but I'm trained to do that, right? So you go to the bathroom and your urine is maybe a little smellier than normal or maybe a little bit darker yellow. That type of urine is irritating to the bladder, and that's what's going to happen when you're not having enough water. So actually, by drinking enough water, we can decrease trips to the bathroom and leakage. Another thing, there are certain foods and drinks that can irritate the bladder. So common ones are going to be carbonated beverages, caffeine, spicy foods, kind of acidic foods, that sometimes if you are sensitive to that, by cutting back on those kind of things, we can actually see improvement in bowel and bladder function as well.
Well, we've heard from Craig, and he's wondering how MS specifically affects the pelvic floor in men. And what are some common related symptoms that might be experienced by men with MS?
Yeah, so that's kind of maybe the nice thing about pelvic floor. It's going to affect both men and women fairly similarly, where again, they may be weak, but we're also going to tend to see muscles that are kind of over tense. The interesting thing in men is pelvic floor tension, which can happen with MS, can also kind of mimic prostate enlargement types of symptoms. So maybe not emptying your bladder well, poor urine stream, frequent trips to the bathroom, urgency, constipation, things like that. So with those symptoms, specifically in men, we do want to have a prostate screen, even as PSA, just to clear things out. But I've had a lot of men that we've done pelvic floor rehab and really resolved a lot of those symptoms as well.
Are there any specific exercises or lifestyle changes that have proven effective in strengthening the pelvic floor muscles in men with MS?
Yeah, that's kind of the other fun thing. They're really going to be very similar. So Kegels, men, they have a pelvic floor too. So doing Kegels, contracting, relaxing through the pelvic floor, hip, core strengthening. A lot of men kind of tend to develop more firm, harder abdomens, not in a good way as they get a little bit older and with MS. So doing some hands-on releases to kind of release through that, deep breathing types of exercises can all help improve the function of the pelvic floor. And then sort of the same lifestyle changes, enough water, decreasing bladder irritants, things like that.
Brian tells us that he's heard that pelvic floor rehabilitation can help address sexual dysfunction or decrease sexual satisfaction among people with MS. And Brian wants to know whether that's true.
Yes, actually, pelvic floor therapy has been proven to help with sexual function and pleasure, both in men and women. So a little bit of both, but maybe more specifically geared towards men. Your pelvic floor needs to be able to relax really well to allow blood flow into the penis to attain an erection, but also contract to maintain it. So that's going to be something that's important. We need to have good coordination to relax, but strength to hold that in. By doing pelvic floor therapy and Kegels, we improve blood flow to the pelvic area, and that for both sexes can help improve sexual satisfaction. And they also are involved in orgasm or the pleasure response, and that's more of a strength and coordination thing too. So the better functioning those muscles are, the better sexual experience individuals can have.
Lee wrote in, and they're wondering whether there are specific exercises or techniques tailored to the needs of transgender individuals undergoing pelvic floor rehabilitation, and how do they aid in post-operative recovery after gender-affirming surgeries?
Yes, absolutely there is. So this question is going to be hard to get specific because it really depends on maybe what surgeries were performed or what an individual feels like is right for them in a transition process, because maybe they want to undergo this surgery but not this other specific surgery. But by working with a pelvic floor therapist, let's say first post-surgery, it's really similar to any kind of other surgical process. We want to make sure we have good motion within a scar tissue or joints that are close to the area. By doing sort of guided kind of specific exercises, we can improve blood flow to the surgical area, which can help with healing. Also, physical therapists are good at kind of going through modifying daily tasks. So usually after transgender surgeries, we'll have different restrictions, so we can kind of help go through maybe how to get through life with various short-term restrictions we might have. Physical therapy also can be helpful for individuals who decide that surgery is maybe not an appropriate part of that transition process or not at this time. So a couple of examples for that. So say a transgender man who is binding through his chest, that can sometimes cause restrictions to the front of the shoulder or the chest and cause pain. So exercises to kind of strengthen the back and open up through the chest a little bit. Or a transgender woman who's doing a tucking type of procedure can cause, I shouldn't say procedure, but like that's what they choose is right. That can cause growing pain and pulling through the abdomen. So different exercises to stretch through some of those structures can really be helpful for those people.
Well, you shared some great information with us today. What would you say are the top 3 takeaways that you'd like our viewers to remember?
Yeah, this was hard, but I think I've got them for you. Number 1, your pelvic floor really can be too weak or too tense, or sometimes both. The good thing is there are things you can do that we've kind of talked about, whether it's various exercises or lifestyle changes that can really help improve pelvic floor function and help improve your quality of life. And I guess to kind of piggyback off of that, number 2, lifestyle changes, make sure you drink enough water, avoiding any bladder irritants you may have, or things that people can do on their own even that might positively affect bowel and bladder function. And really, number 3, if you're experiencing any type of bowel or bladder issues, go and see a pelvic floor physical therapist. We're usually pretty much able to tell within a visit or two if we can help, number 1, which more often than not we can, and then what kind of exercises you can do at home, what things we can do in the clinic to really help improve quality of life.
Thanks for sharing your expertise with us, Jill. We have some time. Let's answer a few more questions from our viewers.
Yeah.
We heard from Grace. She reached out and wants to know how she can find a physical therapist who specializes in pelvic floor rehab.
Yeah, so pelvic floor rehab is kind of interesting in that you do want to try to find someone who has had some training and experience, because it's a field that takes a little bit more to kind of learn about. One way is to go on our professional website. So it's the American Physical Therapy Association, or APTA. Oh man, I should have looked at this. It's either .com or .org, I'm sorry, but if you do one of them, you'll find it. There is a Find a PT tab up towards the top. So you can go in the Find a PT and enter your zip code, and it should find someone close to you. In the APTA, we have our own pelvic health association called the Academy of Pelvic Health. They will also have a Find a PT. There is another association called Herman and Wallace, and you can Google all these and you'll find it. And we'll also have Find a PT. A couple things maybe to look for someone who has a little bit more training would be a WCS, so Women's Health Certified Specialist, PRPC, Pelvic Rehabilitation Practitioner Certified, or CAP. Those designations Just prove you've gone through more training and testing to be able to treat people of a higher level.
Alex is concerned about having embarrassing accidents when they have a strong urge to use the restroom, as well as how to avoid having to wake up to urinate in the middle of the night. You have any tips for Alex?
I do. So we have what we call urge suppression, and that's when you get that really strong urge and you're nervous you're not going to make it in time. So with urge suppression, there's really 3 things you need to remember. And this can be useful at night when you wake up and don't want to go quite yet, but this can be very useful during the day as well. So those 3 things are stop, I'll get into it a little bit, Kegels, and breathing. So stop is basically don't rush to the bathroom right away, because what you've probably experienced is if you get that strong urge and you rush to the bathroom, it gets a lot worse the closer you get because your nervous system is ramping up a little bit. So stay where you are. Stop is number 1. Kegels, 5 to 6 pelvic floor squeezes, just kind of squeeze, rest. Because your bladder sits on your pelvic floor, you can think of the bladder being like the noisy neighbor upstairs, and doing a Kegel is like hitting on the ceiling with a broomstick and quieting it down a little bit. Step number 3 is breathing. So 3 to 4 good deep breaths that calms that urge and nervous system down. What should happen, you might need to do a couple of cycles of Kegels and breathing, but that severity of that urge should decrease so you can walk to the bathroom normally. Number 2, so nighttime, though we do have a few tips that can help at nighttime. Number 1 is try to get most of your fluid intake during the day. I don't want you to cut back on water, but what we prefer is to have most of your fluids in before 2 hours of bedtime. If you need to take some water, maybe to take medications at night, that's okay, but we want most fluid intake earlier in the day. Another kind of strategy I like, we call it double voiding. So going to the bathroom twice, but only before bed. So you go to the bathroom, brush your teeth, whatever else you need to do, go to the bathroom again, just to make sure your bladder is fully empty, and then you go to bed. Those are a couple of things that can be helpful with waking up more often than you want at night to have to go to the bathroom.
Jackie would like to know how she can keep her bowel movements regular and avoid constipation.
Yeah, so water, we're going to go back to that, right? Your colon's job is to absorb water out of your stool. So if you don't have enough water, your stool is going to get extra hard and it's hard to go to the bathroom. Pelvic floor exercises, working on coordination of the pelvic floor, can help the muscles relax when you're actually on the toilet going to the bathroom, make it easier to go. There's also a certain position, sometimes sitting on the toilet can help relax those muscles and make it easier to go to the bathroom. So feet flat on the floor. I don't know if you're able to see me here. And then, not a whole lot, but leaning forward, resting your elbows on your thighs. That helps open up through the pelvic floor to make it just a little bit easier to have bowel movements.
Susanna tells us that she's aware of the benefits of doing Kegels, but she's uncertain that she's performing them correctly. How can she ensure she's doing Kegels correctly?
Yes, and it's a good question. As we said before, we found up to half of individuals, and that's not even, it's males and females, aren't doing Kegels correctly. I guess I should say number 1, go see a pelvic floor physical therapist. We will be able to tell really immediately if you're doing them correctly or not. The nice thing about that is we can provide coaching on kind of how to do the Kegels correctly should you need. But if you're looking for a way to do it at home, when you're going to the bathroom and urinating, try to stop the flow of urine if you can kind of cut that flow off. Side note on that, we don't want people to be doing that on a regular basis. By stopping the flow of urine on a regular basis, it can kind of maybe confuse the bladder and pelvic floor a little bit, and actually in the long term make bladder issues worse. But every once in a while, to see if you can do it, just so you know you're doing the exercise correctly, then it's okay.
Well, I want to thank everyone who submitted some excellent questions, and thank you, Jill, for being with us today.
Yes, thanks for having me. It was a pleasure.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. You can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on MS, please be sure to visit the Society's website. You'll find research updates and news, information on connection programs like self-help groups, and you'll hear about ways to get involved and upcoming events that are taking place near you. Remember, you can connect with the National MS Society and others affected by MS on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And I hope you'll join me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at
If you guys haven't already,
realtalkms.com,
make sure you
Apple
use this link
Podcasts,
to
Google
enter
Podcasts,
into the
Spotify,
giveaway
Amazon
on Vast.
Music.
We are doing a giveaway on Vast for a flavor bundle of one-shot energy chews. I'm going to send you guys three of my favorite flavors, which is the dark matter cherry, the orange mango, and the infected raspberry. And I'm going to send them directly from One Shot to you guys. That way you guys get tracking availability for that. So make sure you use that link. And then when you go there, make sure you enter in the secret code MSSucks on the website for extra entries. As well as use the channel point redeem for the Vast giveaway entry, which should be available for everybody. Yeah, this little button right here. To that one. Make sure you enter that one. And I forgot to. I keep forgetting to bring that up to people when they come in and follow from the Vast site, and I keep forgetting to bring it up. Anyway, we're gonna go. No day stream tomorrow because tomorrow's Friday and I'll be at my part-time job. So if I have another stream, it probably won't be until, I mean, it might be the night of the weekend, most likely Sunday. So if I see you guys before then, great. I am thinking about doing streams while I'm at work, but it'll just be on my phone, so like the sound alerts and everything won't really be there. At which point I'd have to turn off the sound redeems in order to make that happen. I mean, I could do it, but you guys would just waste your channel points. Yeah, I just haven't quite thought about that yet. I mean, I thought about it, just haven't decided to pull the trigger because then I'd have to, like, I could zip tie my selfie stick that I bought to, like, my chair. And then my chair would essentially just be my stand, and I just have to make sure my phone is plugged in with my battery bank. And then I don't know how long the battery bank would last while plugged in with the phone and vice versa. Yeah, just thinking of different things. And then I'd also need a way to quickly mute because I'll be, my second job I take personal information like names and addresses, which y'all don't need to know that shit. So I have to think about headset options to be able to do that with. My headset, my Bluetooth earbuds that I had, one broke. So it won't hold over my ear anymore. And I don't know if I would, yeah, I don't know. So I'm thinking about different things, but whether or not you guys hang out when I'm working is a whole other story. You know, you guys don't hang out when I do this, so who knows. But we'll see you guys in the next one. I love all of you.